My name is Nishant. I am based at Mumbai head office and taking care of strategy and marketing for Conclave. It's my great pleasure to welcome you all to today's 14th ENT Conclave here in Mumbai. I would like to extend my warm welcome especially to our esteemed speaker who are traveling across and be with us today here, Dr. Shirish Ghan from Nashik, Dr. Maruti Kalyankar from Aurangabad, Dr. Gaurav Medikeri from Bangalore, and our two esteemed speakers who are on the way, Dr. Ashim Desai and Dr. Divya Prabhat. Dear doctors, Alkem has always at forefront to support the cause of otolaryngology across India. And conducting ENT Conclave every year is one such endeavor in the same direction. So doctor, this time in 14th ENT Conclave, we have added 3 different flavors. We are conducting ENT Conclave in 10 different cities in India. And at every center, as I mentioned, there are 3 flavors which going to be have. There are a local speaker who is representing the respective state. Also, the speaker who is invited at every location, who are traveling from the different place, different state to the particular location. And moreover, we are having an international speaker, Dr. Robert Vincent, who is going to talk on stapes surgery from its basic to complications. So dear doctors, now without any further delay, I would like to request following dignitaries to please step forward and have a formal inaugural lamp lighting of the 14th ENT Conclave. May I please request Professor Dr. Milind Kirtane sir, all esteemed speaker, Dr. Maruti Kalyankar sir, Dr. Shirish Ghan sir, Dr. Gaurav Medikeri sir, our cluster head Hari Krishna sir, our respected BU head Mr. Prince Uppal, Mr. Rana Bose, Mr. Vikas Seth, Mr. Argadas, please come forward for inaugural formal lamp lighting of the conclave. Thank you, respected doctors. Now I would like to request, so as I mentioned, 10 cities, 10 different cities, Mumbai, Patna, Guwahati, Bhubaneswar, Indore, Bangalore, Hyderabad, Ranchi, all these 10 centers, we are having the same kind of format. At every center, there are 2 invited speakers who are travel, and there are local state speakers also who are going to have talk on different topics within the subject of otolaryngology. So now I would like to request our AVP, Mr. Prince Uppal, to please come on dais and set the context for the event.
Thank you, Nishant. Good morning, doctors. On behalf of Alkem, a very warm welcome to all the esteemed delegates, experts, and distinguished guests to the 14th edition of ENT Conclave in Mumbai. A very special welcome to Professor Dr. Milind V. Kirtane, who has been the guiding force, handholding us in designing and conceptualizing the ENT Conclave from last 14 years to bring best of its class, to bring some of the brightest minds in the field of ENT towards promoting science, knowledge, and skin enhancement in the field of otorhinolaryngology. At this moment, may I request our cluster head, Mr. Hari Krishna, to felicitate Professor Dr. Milind V. Kirtane. Please, sir. Sir. Thank you, sir. This Mumbai chapter is the major hub today, and there are 9 other centers as mentioned by Mr. Nishant. And each center is having its own flavor of deliberations where the speakers have been invited to share their expertise and disseminate knowledge in the field, amongst the ENT fraternity. Here, a special welcome, along with Dr. Professor Milind V. Kirtane, we have Dr. Maranti Kalyankar, Dr. Sirish Ghan, Dr. Gaurav Medikari, Dr. Divya Prabhat, who is on the way, and Dr. Ashim Desai. From last 5 decades, Alkem has been impacting lives through path-breaking research and innovation. There has been a lot of exemplary work for good health by adhering to best standards of quality while providing accessibility and affordability for the improved patient outcome. So the Alkem has been on the forefront of promoting science in the ENT, as this is a specialty which is very close and very dear to us. We express our gratitude for squeezing out your time, a valuable time, on this Sunday morning, and this speaks about your expertise, about your passion to make a difference, and that's what makes this ENT event a special initiative. Now, not taking much of time, I would request Professor Dr. Milind V. Kirtane to officially unveil the scientific agenda and set the tone of the meeting. Over to Milind Kirtane, sir. Thank you.
At respective centers, I request all respected speakers to please hold for a minute. Our mentor, Kirtane sir, we are going to address us and guide us. So I request respected speaker, please hold for 2 minutes.
Dear friends, thank you for coming for this program of the 14th ENT Conclave, organized through courtesy of the grant from Alkem Pharma. They've been doing it for the last 14 years, and the spirit of the conclave is entirely pure science. As you can see, we are different from what we did last time. Last time it was live surgery. We keep on changing the patterns because of the demands that we get from people. and we try to squeeze in that period of time, the maximum amount of information that can be dispersed. This time it's show videos of surgeries and then have 10 minutes time after your 20-minute presentation for question and answers. And my request to all the speakers is to try and stick to that time, because the next speaker cannot be delayed. And at 12 o'clock sharp, we are going to have Professor Vincent talking to us from France. So we have to be there on the dot at 12 ready. The topics also that we select are not for surgeons to show their fantastic repertoire of surgery, chest beating, big tumors which the people have removed, which only they can do. The idea is to select topics where the people attending can take home something which they can apply in their own practice. So you'll find that most of the topics are where commonly encountered issues in your practice. Knowledge is great only when it is shared, and I hope this is going to be a learning experience for you, which is by listening to the speakers, but more importantly by interacting with them. So please be forthcoming in whatever doubts, questions, comments that you have after the speaker's presentation, because this interaction is what will enhance the learning. Two things. As I said, the speakers have requested to keep to time. Secondly, the tea break, the tea will be served to you where you are sitting, so we save a little time going ahead. For future conclaves, my sincere request to all the delegates is to talk to them and to their friends and say, suggest three things. A, the format in which you would like the conclave to be. You want the same. You want live surgery, you want seminars, you want panel discussions, whatever you feel. Suggest the topics that you feel you want to have covered in the next conclave, so we can target it accordingly. And number three, if you would want to suggest the names of some speakers in your area, or if you yourself feel that you have something to contribute, please write to us so that we can adjust that in the next conclave. So with this, I would say, I wish you all a very fruitful and enjoyable scientific session ahead. Thank you very much.
Thank you, sir. Thank you for your guidance and address. I request the AV guy, please now will continue the Mumbai agenda. Yes, yes. And I also request to please continue with the respective agenda at respective 9 centers. So now we are having a first talk from Dr. Maruti Kalyankar today. It's my pleasure to introduce you, sir. Dr. Maruti Kalyankar is based at Aurangabad. He is a director at Kalyankar ENT Hospital and practicing since 1993. He has organized more than 10 workshops at his Kalyankar ENT Hospital at Aurangabad and also presented various papers in national and international conferences on otology and endoscopic ear surgeries. He has moderated panel on otology and endoscopic sinus surgery. He is also organizing secretary for Maharashtra State Conference on MedCon 2012. Recently, he has organized live surgery workshop in April 24 at his Kalyankar ENT Hospital at Aurangabad. So I request Kalyankar sir to please hear and have your talk.
Hello. Respected Padma Shri Dr. Bilind Kirtane sir, my friends, speakers of today's conclave, and dear friends. Good morning to everybody. I'm going to present this topic today is the retraction pockets and its surgical significance. In a routine, for every day we come across a lot of cases of retraction pocket in our OPD. Well, the retraction pocket, by definition, it is the invasion of the tympanic membrane into the middle ear space. It frequently a result of chronic otitis media with a prolonged eustachian tube dysfunction and can form the adhesions with the surrounding structures, mainly the ossicular chain and the promontory, and there is an accumulation of the debris and epithelium which predispose to the form the cholestoma. Then few words about the anatomy and histology of the normal tympanic membrane. The external epithelial layer, it is composed of stratified keratinizing epithelium as a property of migrate from center to the periphery. And the middle ear, which is formed by the connective tissue and predominantly the collagen fibers, and the thickness is about 0.04 to 0.9 mm. And it contains dedicated vascular and nerve complex, and inner layer is the mucosal layer. Then the pathophysiology of retraction pockets, it is mainly because of negative middle ear pressure, that is because of eustachian tube dysfunction, and there is a disruption of the gaseous exchange in the middle ear mucosa and middle ear cleft as such. There is a different relation between the otitis media and pathogenesis of the retraction pocket. Inflammation is responsible for the degeneration of the lamina papyracea of the tympanic membrane. There is an increase in the surface area of the tympanic membrane, so there is a poor epithelial migration, and the presence of chronic inflammatory changes in the tensile tympanic muscles that lead to the retraction of the malleus, which is one of the reasons where there is a, because of that is a retraction. So in the retraction pocket, there is a sustained pressure difference and or the inflammation that lead to the destruction of the collagen fibers in the lamina papyracea, and there is a inflammatory mediators and the cytokines that lead to the release of collagen and that result to the degradation of the double layer. Here you can see there is a retraction of tympanic membrane. It is going on the incus and the stapes. Here there is almost total collapse is there. Here you can see there is a total destruction of the ossicular chain, and here it is a complete atelectasis of the ear, and there is a destruction of the attic also. So the classification, there are two classifications. There is a Sadez classification part tensa, where there is a mild retraction of the tympanic membrane. The lateral process of the malleus is prominently, you can see. Grade 2 type of retraction, there is a tympanic membrane goes on the incus or the stapes, where grade 3 tympanic membrane is onto the promontory but is not adherent to the promontory, and grade 4 there is adhesion of the retraction pocket to the promontory, and in grade 5 there is atelectasis of the tympanic membrane with a perforation. Then the classification of the pars flaccida retraction by TOS, that is the grade 1 is the small attic retraction, grade 2 pars flaccida adherent to the neck of the malleus, grade 3 is a grade 2 plus minimum scutum erosion, and grade 4 is a deep retraction pocket which is unaccessible. There is an accumulation of the keratin. So patient present with a retraction pocket, mainly it is asymptomatic, or when there is a destruction of the ossicular chain, there is a patient present with the conductive loss or discharge from the ear. Clinical diagnosis, otoendoscopy is the best one. We have to see whether retraction pocket is a reversible or not. Ask patient to do the Valsalva, or with a pneumatic otoscope you can see the flexibility of the retraction pocket. The three main criteria we should assess for the retraction pocket is the localization, whether it is in the posterior superior, epitympanum, or other retraction pocket as a whole. Then the quality of covering epithelium also we have to see whether it is a dyskeratotic or it is a normal epithelium. And lastly, we have to see whether this retraction pocket is adherent to the ossicle or adjoint the bony margin. What is the natural history of the retraction pocket? There are 4 destinations of the retraction pocket. Either they get resolved by their own, because if you treat the underlying cause, that is usually the upper respiratory infection and the recurrent infection of the middle ear, they are stabilized. Most of the retraction pocket for even quite long time, they can be a retracted pocket, but they don't give any destruction of the ossicle unless there is a accumulation of the keratin and there is a perforation. Lastly, the keratin accumulation and the perforation is the last fate of the retraction pocket. Then the mechanism, that is a tubal dysfunction. Here you can see there is a middle ear fluid, and this is because of grade 4 adenoid hypertrophy. There is a congenital malformation, mucosal edema, adenoid hypertrophy, or the recurrent upper respiratory infection, otitis media effusion is the main cause for the middle ear inflammation and the retraction pocket, and impaired middle ear ventilation is another cause. Here you can see the eustachian tube is quite healthy mucosa around the eustachian tube. Over here you can see the eustachian tube opening, but this is the patient with a chronic rhinosinusitis where there is a constant postnasal drip, recurrent infection. See the mucosa of the eustachian tube orifice over here. Because of chronic inadequate tube opening, sustained tubal dysfunction, this patient lead to the retraction pocket. See, there is a retraction pocket on the right side, on the left side. Then the word about the middle ear ventilation pathway, which is important to understand, because the anatomical variation of the tympanic compartment with their aeration pathways that involve pathogenesis of middle ear inflammation that lead to the retraction pathology. There are two routes. There is anterior ventilating route that is in between the cog, over here, and the cochleariform process that ventilate the Pussac space and the anterior epitympanum, whereas the posterior ventilating route, that is mainly the tympanic isthmus, which is the main route for ventilation of the attic and the mastoid antrum. Here this is the lateral view where you can see with a intact, with a functioning eustachian tube. This is the anterior route which is going in the attic and the adductor antrum and mastoid. Here this is the tympanic isthmus. You can see this is a ventilating route over here. Now this is a picture shows, the microscope picture shows the tympanic isthmus. This is a right ear endoscopic view where you can see the ossicular chain, you can see the tympanic isthmus which is ventilating to the adductus and maxilla. This is the view from the mastoid. This endoscopic is in the right mastoid. Through the adductus you can see here there is a cochleariform process, you can see the malleus, you can see the incudostapedal joint, and up in the corner above you can see the chorda tympani. This is a view from the mastoid antrum. So there is a epitympanic diaphragm. This concept we have to understand much to know the ventilation pathway. This epitympanic diaphragm will separate the attic adductus area from the mesotympanum. There are the three malleolar ligaments, that is anterior, lateral and posterior malleolar ligament. Here you can see the anterior, here lateral, and this is the posterior malleolar ligament. These are three ligaments, posterior inguinal ligament over here posterior inguinal ligament, and there are two purely the membranous fold, that is the tensor fold and the lateral inguinomalleolar fold. This form the diaphragm which separates the attic area from the mesotympanum area. When this get blocked, either because of any granulation tissue, fibrous band, cholesterol granuloma, there is a poor ventilation of the attic space, and then starts the blocking of the ventilation pathway and the retraction pocket. This is the video. You can see there is a tensor fold which leads the clear separation between here from the anterior epitympanum and the protympanum. This video shows this is the anterior, this is a eustachian tube opening. This is the anterior root. Sometimes the tensor fold is absent. And here you can see this is a video of the adductus and antrum. We are in the right antrum, the right mastoid antrum with a 0-degree endoscope. Now we can see this is the body of the incus. This is the processus cochleariformis. This is a tensor fold is there. This is blocking the anterior ventilation. But here you can see this isthmus is open. You can see the malleus handle. This is the incus. This is the incudostapedal joint. This is the stapes head, and here you can see the chorda tympani. This ventilation pathway is very important for the aeration of the adductus and antrum in the mastoid. Well, the adductus and antrum is the most susceptible area to get blocked. Here in this first picture, you can see there is a mucosal bands. Here you can see the upper part of adductus is antrum. Here this adductus is get blocked because of tympanosclerosis, and where here there is totally blocked with the edematous tissue. So loss of, when there is adductus antrum block, there is a loss of reservoir, inactivation of the buffer system, negative medullary pressure due to the absorption of the ear, and ultimately there is a retraction pocket. Then how to manage the retraction pockets? What is the strategy? Strategy is preventing and relieving the hearing loss and the cholesterol formation. The first strategy is watchful waiting policy. Carefully follow the patient in the OPD as there are a lot of asymptomatic patients. Then increase medullary pressure by doing Valsalva, putting a ventilation tube in an early stage of recurrent otitis media, particularly in the childhood area. Then the nasal treatment, that is the disease of the nose and the paranasal sinus, stitch tube surgery, and the surgery of retraction pocket. Sorry. In a OPD, routinely you can see a lot of retraction pocket patient where this is a deep, asymptomatic deep retraction pocket. Where you can see this is a retraction of tympanic membrane as a whole. Here the retraction is over the malleus. Here you can see the destruction of the scutum. You can see the incudomalleolar joint, and you can see the even malleus head and incus. Here you can see the chorda tympani, scutum destruction. Here the attic wall and the posterior superior bone is, and this is a very severe retraction pocket. So the simply putting a ventilation tube which gives a very good hearing improvement in the patient also, and further sequelae can be avoided, and in a due course of time this ventilation tube get extruded and you can have a healthy medullary mucosa. Then regarding retraction pocket surgery, there is simple excision of the tympanic membrane which is retracted, or fascia and the cartilage tympanoplasty, and the mastectomy for the different stages of cholestoma. Before going for the surgical video, I would like to show the different images where the retraction pocket can damage the underlying ossicle. There is an erosion of the ossicular chain. This is from simple, there is a necrosis of the lenticular process over here. Here, because of retraction, there is an indentation of the chorda tympani over the malleus. Here there is a disruption of the encodostapedial joint. Here there is a disruption. Even in the extreme cases also, there is a destruction of the suprastructure of stapes. Here in this patient there is a handle of malleus is also get necrosed. Incus is also get necrosed. See, the suprastructure of stapes is absent. So such type of extreme destruction of the ossicular chain can happen in the retraction pocket patient. These are the few surgical videos. Is a patient with a small retraction pocket with laryngitis, presented with ear discharge and conductive hearing loss. This is a 2-minute video which shows how to deal the retraction pocket. Sometimes you may get very thin skin of the posterior canal wall. Just do the canalplasty, go up to the bottom of the retraction pocket. Meticulously with a sharp elevator, you elevate the retracted thin tympanic membrane. Here you can see this retraction pocket is plastered to the incus. As I said, with the dissection should be very sharp and proper suction cannula is used. Just should not damage the underlying mucosa or it will not pull the things. Now here you can see there is a discontinuity of the ossicular chain over here. And another thing, separation of the chorda tympani with the retracted tympanic is really a challenge job. But with the patients, if you separate this mucosa over, then you can now sometimes we can get the thick secretions in the ventricular space. Now I am again checking the continuity of the ossicular chain over here. Sometimes because of long surgical exposure, there is a drying of the chorda tympani. You can hydrate the chorda. Here you can see there is even the slight destruction of the handle of malleus. Now again I am checking the integrity of the ossicular chain. In this patient, I plan to just cut out the disease long process of the incus, and I am planning to keep the cartilage. Now here you can see there is a small lenticular process. Again, remove the lenticular process before doing any ossicular chain reconstruction. Now this is a cartilage from the hypotympanum to the stapes head, and there is a another small piece of cartilage which is filling this defect and put a graft and come out. This is another case where you can see it is a retraction pocket which is going in the middle ear. We have to excise this retraction pocket. Again, the canaloplasty, sometimes we can see very thick glue which is coming in the from the posterior superior region. Remove the overhang. Go behind the retraction pocket. It's a quite edematous mucosa over here. Separate the chorda tympani from the tympanic membrane. Now here again you can see there is a thick secretions which are in the middle ear. Now this retraction pocket which is attached to the incus, there is a destruction of the long process of the incus over here. Now cut the mucosal band. If you see over here, this is the retraction pocket which is sitting on the head of stapes. Now separate this retraction pocket from the stapes. You can see this is a small lenticular process of the incus which we are separating from the head. Again with a sharp dissector, elevate this all thick mucosa. See that there is a separation of the stapes. Stapes suprastructure is intact. Sometimes we get all this, some fibrous band or the mucosal band around the ossicular chain. Now see, like this we have separated the retraction pocket. And next one is the excision of the retraction pocket. So we have to remove all this diseased tympanic membrane. Now the reconstruction is again the putting a temporalis fascia, and there is a cartilage from hypotympanum to the stapes head. Supported with the chorda tympani laterally, and you can see here is a stapes. This is a properly placed cartilage from hypotympanum to stapes. Another cartilage piece is over there just to avoid the further retraction pocket in the postoperative phase. And this is another case where there is a retraction pocket with a cholestoma formation. Elevation of the tympanomeatal flap, doing the canaloplasty. Now see this cholestoma sac, this is going middle to the incus. Just go beyond that retraction pocket or the cholestoma sac. Don't leave any squamous epithelium behind, otherwise there are chances of recurrence. Now you can see the footplate of the stapes over here. Here this is a stapedius tendon which is get engulfed in that retracted pocket, cholestoma sac. Now with a sharp instrument you can dissect out the cholestoma sac from the stapedius tendon, even it is adherent to the incudostapedial joint head of stapes. Now there is a separation of the chorda tympani and excision of the cholestoma sac. Here the ossicular chain is intact in this patient. This is going middle to the incus, but with a pick or a sharp instrument you can see. Now this is where getting cleavage at the round window niche. The clearance of the cholestoma from the tympanic, facial recess and the sinus tympani is very important. At time you can take the help of endoscope to clear this area. Now see, there is a separation of the retraction pocket from the promontory. This is the promontory, this is the round window niche. it is adherent to the promontory, but the mucosa below is quite healthy. You can see this is a Jacobson nerve. You can separate the mucosa, you can cut the fibrous bands and elevate all the tympanic membrane from the promontory. Now again the reconstruction is same. I have kept the cartilage from the hypotympanum to the stapes head. See, this is the cartilage from hypotympanum to the stapes head, and another small cartilage over here. This is a near normal than middle ear space now, and if you keep a tympanometer flap, then you can see this is the this one perforation membrane shows initially seen. This is another case. This is a atelectasis. The total tympanic membrane is get adherent to the promontory and it is going in the mastoid antrum. There is a cholestoma formation. So this is the inside out at aticoantrostomy. Now this all sac is lying on the over the middle wall of the mastoid. Then meticulously separate the sac from the underlying bone. Try to preserve the mucosa. Now here you can see there is a destruction of the facial canal. This sac is directly over the facial nerve. We can peel out the sac from the facial also. See, the facial nerve is below. This is the Follipine canal. This is the clearance of the disc in the anterior. Now you can see there is a facial nerve in a canal. And the cholestoma is going. See, the cholestoma is lying over the foot plate. So with a suction and the sharp instrument, just peel out this mucosa without damaging the underlying promontorial mucosa or the foot plate mucosa. Like this, we can elevate all the plaster drum to the promontory. See, we are preserving the mucosa, promontorial mucosa. Here there is this Jacobson nerve being separated from the retraction. We can preserve the nerve also over here. And like this, we have elevated all the retracted drum. Now we can see the healthy middle ear mucosa. Now there is another case where there is epitympanic diaphragm blockage. There is a case of attic retraction with some laryngitis sort of thing. There is a deep retraction pocket is elevated. You can see the necrosis of the head of malleus. Incus is still there. There is incudostapedial joint is there. All three ventilating pathways, they are open in this patient. This is a posterior. This is again tympanic. This one. This is the anterior. And if you open the mastoid in this patient, there is a mastoid block. This is all edematous tissue which is blocking the adductus edentrum. Open this blockage and go for free water flow test. Establish the patency of the adductus. See, from the mastoid antrum, if you give the wash, you can see the free flow of the water in the mastoid. Then you reconstruct this part of attic with a cartilage and put a graft. Then a lot of people, they are now doing the cartilage tympanoplasty. The choice is for the recurrent perforation, then large perforation, uncontrolled shrink retraction pocket, atelectasis of the tympanic membrane. Of course, with temporal fascia reinforced with the cartilage gives the better anatomical result, but the concern is about the thickness and the stiffness of the cartilage. The advantage of the cartilage, of course, compared with the tympanic membrane, these are the advantages, and disadvantage is that, but the cartilage may seen as a mass impending vibration of the tympanic membrane cavity and also may hinder the visualization of the development of the cholestoma in the behind the tympanic membrane. There are again a few images which shows how the small retraction pocket, this small retraction pocket with laryngitis can give rise to the extensive ossicular chain destruction. In this patient, there is a destruction of the long process of incus. Even suprastructure of the stapes is gone. There is a small head of stapes with a stapedius tendon over here. This is a case of retraction pocket. See that there is an attic retraction over here. If you elevate the retraction pocket, there is an intact ossicular chain behind. Anterior epitympanic ventilation route is open. You can see there is a small lenticular process necrosis, and see this the route is open. And the reconstruction of the attic with this, I preferably use a concave cartilage as it is a very soft and it can accommodate the shape of the attic, and augmented with the temporalis fascia, and this is a almost near normal tympanic membrane with attic reconstruction. This is another case where you can see there is a pars tensa retraction. This retraction is giving rise to a large cavity in the middle ear that is going to that is giving destruction of the suprastructure of the stapes. Incus long process is gone. This is the retraction pocket area, and in this patient there is a ventilation route is open. There is again the suprastructure destruction is there. This is a case where you can see suprastructural stapes is gone here. This is the old case where I use the titanium prosthesis. TORP, that is a total prosthesis, kept over the footplate and is supported with a cartilage, and again the reconstruction of the attic region and this one. Then the take-home message is that the careful assessment of the retraction pocket by otoendoscopy and audiological evaluation, address the nose and nasopharyngeal pathology, evaluation of the eustachian tube dysfunction, watchful waiting or the surgical intervention, we have to take the call. By doing a regular follow of the patient, and the aim of surgery will be preventing and improvising the hearing result, and early surgical intervention for the cholestoma is must. Thank you. Thank you, sir.
You'll have to agree this was one of the most clear, precise presentations you've seen. Quality of pictures essential, the quality of surgery fantastic. We have about 2 minutes left. Any questions?
Good morning, Dr. Kalyankar. Very nice videos, very nice hand. Sir, two things. One is any role of silastic whenever you are operating on a retracted role of silastic in the middle ear.
Silastics. I am not using silastics.
And second thing, all your cases you open up for a simple mastectomy to establish attic patency?
Now, when I have doubt of ventilation pathway block, and then I can open the master antrum. Doing a control hole mastectomy.
So control hole not in every case if it's a dry perforation.
Not in every case.
Yeah, Vikram, quick.
Yeah. So how do you address the nasopharynx, and do you canalize the eustachian tube to flush it in your cases?
No, sir. Basically, now there a lot of people they are doing eustachian tube surgery, canalization, and dilatation of the eustachian tube. But at our place, I am not doing eustachian tube.
No, he was asking whether you flushed the eustachian tube.
No, sir.
Okay.
By doing nasal endoscopy prior to the retraction pocket patient. In every patient who presented with a retraction pocket for a long period, I used to do the diagnostic nasal endoscopy and assess the nasopharynx.
Thank you very much. Before we end, just one question to you. You made a mention that you should have an adequate suction. So just tell us what you mean.
Size of the suction.
So tell us what you mean by that. Just what size would you recommend?
It should not be a bigger size. Otherwise, the retraction pocket get catch in that, and then you lost the integrity of that retraction pocket for elevation. Might be around 20, 19 suction tube, depending upon what size, what thickness of the.
And depending on the strength of the section, you decide whether you want to put your finger on the.
Yeah, sir.
You can release that so that you don't. Otherwise, the whole thing tends to get sucked out. So one question to you always bothered me. When we do a canal wall down mastectomy, huge cholesteatomas, we used to knock off the chorda tympani in those days very easily, and no patients complained.
Sir.
When you do so much dissection around the chorda, the stretching of the chorda, do they complain? And if you have to sacrifice the chorda in a tympanoplasty, have you had complaints?
In tympanoplasty, I'll preferably dissect out meticulously the chorda tympani without giving much stretch. But in the cholestoma cases, cutting the chorda, patient doesn't have that much stage disturbances.
Yeah. Yes. You don't know why.
Might be because of chronic neuritis sort of
thing. Any suggestions from the audience why In a cholesteatoma, you cut the cord of the patient, doesn't bother you. In a stapes, if you cut it, they keep on.
Sir, the nerve is already dysfunctional. So cutting that nerve does not.
So do you think in all our cholesteatoma cases, we should do a gastrometry or taste and see whether it's really defunct? Have they ever come, any cholesteatoma patient come to you saying, "Mere ko taste nahi aata hai before operation"?
No, sir. Sir, chorda tympani stretch is most important only in stapes surgery.
Why? Cholesteatoma patients don't complain of taste loss after cutting, but stapes patients will keep on chewing your brains.
Sir, is it that females complain more about...
Females always complain more, but that's why let's not...
So the matrix,
Sorry.
So the cholesteatoma matrix releases toxins which already makes the nerve dysfunctional.
If the nerve is dysfunctional, the patient complain of ageusia before surgery.
Sir, in stapes surgery, you already given the patient a perfect ear, except for the taste. In the cholesteatoma, in the stapes surgery, you already given a perfect ear after doing the surgery. As far as the hearing goes, the only problem remains is the taste. In cholesteatoma, patient has got multiple problems. Taste may be one of them, so they don't complain.
I think we should do a taste sensation before and after cholesteatoma surgery also to find out what really happens. One of my colleagues did, whenever the chorda was sectioned in cholesteatoma surgery, they did show some amount of inflammation in the nerve. Whether that's a factor. Where's Gaurav? He's keeping quiet. Gaurav, your thoughts on this?
It's not something like in a stapes surgery, yesterday he had taste and today he doesn't have taste.
So it's a sudden loss. Yeah, because the nerves did show changes of chronic inflammation in the nerve sheaths. Yeah. Okay. Thank you very much. I think
Sir,
congratulations on a brilliant presentation. The next one, or you want to...
Kirtane sir.
Nishant, you want to felicitate him?
Yes,
yeah?
sir.
Can I add something?
Yes, please.
Yeah, sir, I want to say that when we are doing the stapes surgery and when the chorda tympani nerve is getting stretched, it actually gives the metallic taste, and that is bothering the patient rather than the cutting the nerve and not having any taste sensation.
You know, autosclerotic surgery is often bilateral after a year or so. So if you cut the nerve on one side and then you're doing it on the other side, you can put the patient to a lot of distress.
Sir,
I
request Kirtane sir to please felicitate Dr. Kalyankar with the token of gratitude.
Who's the next speaker?
This.
Thank you, sir. Now our next speaker is Dr. Shirish Ghan from Nasik. He is director at Yashali Hospital, Nasik. He is also faculty for basics and advanced scalidoscopy courses, University of Geneva. Dr. Ghan, operating faculty at Egyptian hand scalidectomy course at Alexandria at 2018 and 2022. He has had lots of social work he has done, working actively at shared parenting and separate and divorced families. Dr. Ghan has also hobbies of trekking, high altitude trek. He has completed cycling in 10 countries and badminton, national IMA championship 4 times. So welcome Dr. Shirish Ghan for your talk.
Thank you, Nishant. Thank you, Kirtane sir and Alkem for this wonderful opportunity, and good morning to you all. And I'm going to start with a disclaimer. You have seen Maruti's wonderful lecture, fantastic pictures. I don't know whether they are 4K, 8K, 16K, I have no idea. But silendoscopy is done through a fiber optic scope which has 10,000 fibers. So the images we will have to tolerate. Okay? So let's begin. I'm going to talk about stricture management using silendoscopy. Can I have a pointer, please? Just a moment. Can you connect the audio also, please? So, quite a lot of times I am asked why silent endoscopy, and my answer is, where's the audio?
To explore strange new worlds, to seek out new life and new civilizations, to boldly go where no man has gone before.
And I say so because all of us know the anatomy of the salivary glands. We also know theoretically the anatomy of the ducts, but it is rarely that we go in and see that anatomy. That is the basic motivation. What basically is the stricture? It is both the process of narrowing and the narrowed part. Both are called a stricture. It's like suddenly when the road narrows from 4 lanes to 2 lanes, that's what happens in the body. It's a stricture. How do patients present to me with patients of strictures present to me in my OPD? They have recurrent parotid swellings, sometimes associated with meals. I say sometimes because some of the obstructions can give rise to mealtime swellings. The other obstructions, as you will learn later on, are more of the autoimmune process and they are not related to meals. But they generally complain of foul tasting saliva or sour saliva. They complain of dryness of mouth. Now, on examination, the duct is generally indurated, bossylated surface. The duct is tender. This is something which all of us can do. You just have to roll the duct over the anterior border of the masseter when the jaws are clenched, and you can feel the duct. You can feel the difference between the two sides, the tenderness between the two sides. And under the microscope, you can obviously give an external pressure and see pus or saliva coming, thick saliva coming out through the papilla on external pressure. So, how many people are suffering from parotid strictures? If you look at the overall incidence of salivary gland disorders, 80% will be caused by obstructive disorders, 20% are space occupying lesions. And of the 80% obstructive, 40% would be stones and 40% would be strictures, but this is for the entire salivary glands, including the submandibular and the parotid. But if you look at the parotid incidence, the strictures will form nearly 80% of the obstructive disorders. The prevalence is about 1 new case per 10,000 population. In India, it amounts to 130 or maybe now 1,30,000 or maybe by now 1,40,000 cases per year. So, there is a huge case load. What are the different etiologies that cause these strictures? There is an entity called as juvenile recurrent parotitis, adult recurrent parotitis, sialadenitis, which is due to infection, Sjogren's syndrome. 2 important things that we keep on missing is radiation induced sialadenitis and radioiodine induced sialadenitis. Lots of thyroid cancers are being treated by radioiodine, and these patients need to be followed up for their salivary gland function. There are sialoceles which happen. Sialoceles happen because there is a distal stricture, so the proximal duct balloons up, and there is trauma. Trauma can be like road traffic accidents, assaults, or sometimes it can be iatrogenic. Now, how do you diagnose? This is typically a case of ultrasound of a juvenile recurrent parotitis. You will see multiple hypoechoic areas, most of the times reported as multiple abscesses. But mind you, these are not abscesses. These are multiple dilated ducts inside the parotid parenchyma. So, ultrasound is one of the easiest way for us to diagnose. MR scilography, as you can see, this is the parotid duct. You can see different diameters of the duct. Here you can see a very narrowed portion of the duct. So, MR scilography is the gold standard. You will have to talk to your radiologist, ask them to do the same protocol that they do for MR cholangiopancreatography, and you can get wonderful images. Conventional scilography is something which we don't advise because I'll put this question to you. How many of you have cannulated a parotid papilla? Raise your hands, please. Okay, 1% of the entire audience, I think, has, or maybe 10%. So to expect the radiologist to cannulate that papilla, inject a dye and get us a good image is something is asking for too much nowadays. The other thing is if the papilla is traumatized, it gets fibrosed and then your chance for silentoscopy goes away. So I would recommend against asking for conventional silography. As opposed to conventional silography, MR silography does not need any dye injection. The saliva itself acts as the contrast. So let's look at this case. You can see a sudden narrowing in the lumen of the duct, and that green thing is the guide wire. You can see the diameter is nearly the same. This guide wire is 0.6 millimeters. I pass the guide wire through the narrowed portion. I use a modular scope to follow that guide wire. It requires a lot of force. The stricture is quite firm. And then I enter into a spacious cavity. You can see this is the guide wire, this is the diameter of the cavity that I am in, and you can see the further branchings. And as I withdraw, you will see the dilated portion of the duct, these rough edges, some amount of bleeding, and then I withdraw it back entirely, come out. You can see this portion was strictured, this entire segment. This has been dilated, and then over the guide wire I pass a stent. Fortunately for us, these stents are now manufactured in Bangalore and they are easy to procure. Next case. Again, you can see the strictures, very small lumen of the duct. This guide wire is 0.4 millimeters. You can see the difference in the color. And once the guide wire passes, then you pass your scope. Now you can see it's in a larger duct. This is the proximal duct, which is dilated because of the stricture which was distal. And this portion is the stricture which was dilated. I am entering into the stricture and into the proximal duct. Is that clear? Can you see that dilated duct and the stricture? Then you can use a larger scope to dilate further, because you do have balloons, but balloons are costly. They require a larger scope for you to introduce it. And even then, balloons cannot give the pressure which a modular scope, which is a steel kind of a sheath, gives. So I prefer using the scope itself to dilate the stricture, but balloons can also be used. And in the proximal duct, you can see tributaries, and this area is the stricture. Over this stricture, I am going to pass a stent. This stent ideally should remain in place for 4 weeks, but it is anchored to the buccal mucosa. So sometimes it does come out after, say, 3 weeks or 2 weeks. You can reinsert it in an OPD base, because now the papilla and the stricture have been dilated. Again, as I said, these images will not be as good as Maruti's. So you can see this sudden narrowing. At the stricture level, you will see less of vascularity because of the fibrosis that is there. Again, this guide wire and the duct lumen is nearly the same size. And that's how you measure. And once you pass in and dilate the stricture, you will enter into the proximal duct. This takes a lot of time, because to present, I have just, compressed the video temporarily, so it looks like a very jerky movements, but these movements are not jerky, they are very smooth. You can see that part, the rough part, is the stricture that has been dilated. And then you see the proximal duct. That is the distal duct. Distal is close to the papilla, proximal is close to the hilum because that is the way the saliva flows. Now, this is a case of juvenile recurrent parotitis. A lot of patients come to me who have been diagnosed as recurrent parotitis, and there is no entity called as recurrent parotitis, recurrent mumps, sorry, because mumps gives you immunity lifelong. So, there is nothing called as recurrent mumps. It is basically juvenile recurrent parotitis which has been misdiagnosed and called as recurrent mumps. Now, what happens is, if you have seen the videos previously, you look at this video, the entire duct is nearly avascular. If you look at it, it is nearly avascular as compared to the previous this thing. And sometimes you may not have a sudden narrowing in the duct, it is the entire duct that is strictured. So, you may not appreciate it as a stricture, but as you pass the scope, you will realize that it is difficult to pass the scope, and when you withdraw, the duct grips onto the scope. So, that is something. If you notice, this is like a white mucosa, and this is very common in juvenile recurrent parotitis. Generally, it is a self-limiting disease. By adulthood, it will go off, but patients present during the age of 3 to 7, so it is difficult to tell them to wait for another 7-8 years for it to go away. But dilatation helps extremely well in these cases. Again, sudden narrowing, entry into the proximal duct, and sometimes you see multiple segmental strictures, multiple diaphragmatic strictures in the proximal duct, the semicircular structures that you see there, all because this entire process is an autoimmune process. So, when I speak to my patients, I tell them I am going to treat the effect of the disease and not the cause of the disease. So, recurrence is a chance. 80% of the patients do not require any repeat surgery, but 20% require, generally a time interval of 3 to 4 years, and they are quite happy to get a nearly non-invasive procedure done for symptomatic relief. This patient landed up with me, had a superficial parotidectomy done and landed up with this. So, this is the entire procedure. You dilate the parotid papilla using sequential dilators. So, this is the left parotid papilla. You can now see the papilla very clearly. That is the scope going in, the guide wire, and then there was a blind end, because obviously the duct had been transected at some point. It was slightly blue because of the parotocele which was behind. So, I pushed in my guide wire into that blue area, pushed my scope through, and then you can see a huge cavity. See the size of the guide wire and see the size of the cavity. So, now the next task is to find the proximal end of the duct, the hilar end of the duct. So, it is a huge task because you have to search the entire parotocele. You can see the brilliant transillumination of the parotocele, and that is the proximal end which is seen. The guide wire goes into the proximal end, and then you are withdrawing yourself through the parotocele, and this is the strictured part, and then this is the normal distal duct. At the end of the procedure, you pass in a stent over the guide wire, fix it to the buccal mucosa, and if at all if the stent does not come out on its own, then you remove it after 4 weeks. This is post-op day 14, this is post-op day 26. So, pre-op, day 14, day 26 when the stent was removed. Now, this is an interesting case. A few of you might have seen it in one of my presentations before. This lady went to a plastic surgeon. She wanted her cheeks to be sculpted, so she underwent cheek liposuction. The next day, she ends up with this. So, this is a huge parotocele because of injury to the parotid duct by the liposuction machine. You can imagine how angry the patient was. Well, she was on verge of getting in touch with her lawyer, but as in the previous case, this is the same procedure, serial dilatation of the papilla, followed by the scope going in. Then you are in the parotocele. You can see the scope is moving inside the parotocele. We have to find out the proximal end. That is the proximal duct, which is very clearly seen. So, the guide wire stays there, the scope is withdrawn, and a stent is railroaded over this. We are still in the parotocele here. This entire thing is the parotocele. In the parotocele, you nearly feel lost. If there was no guide wire, you would not find out where you were. That is the stricture, that is the damaged section of the parotid duct. You can see the parotocele emptying through the stent. This is pre-op, that's post-op. So, why is stricture dilatation so successful in this case? I mean, we see everywhere else in the body stricture dilatation is not very successful. The physics behind that is something called as Poiseuille's law, which says resistance to a flow of fluid is inversely proportional to the fourth power of the radius. If you look at the flow, it's inverse. Flow and resistance are inverse of each other. So, flow is directly proportional to the fourth power of the radius. What does that mean? If we had a pre-op dimension of 1 millimeter, we increase it to 1.5 millimeter, the flow increases 5.6 times, 5.06 times. From 1 to 2 millimeter, it will increase 16 times, every other parameter remaining constant. And from 1 millimeter, if you can increase it to 2.5 millimeters, it nearly goes to 40 times the normal flow. There is also another Bernoulli's principle which is at work. Bernoulli's principle basically states that as the velocity of the fluid in a tube increases, the lateral pressure that the tube exerts on the tube wall will decrease. So, how does that help us? Because this is in a soft tissue, this was the pre-op state of the duct. So, once the saliva starts flowing through the narrow segment, the pressure that it is exerting on the lateral wall decreases. So, the pressures of the surrounding tissue is relatively more. But if you increase the diameter, then this pressure increases and the tissue pressure is relatively less. So, that is why the success of dilatation is based on these two principles. Complications, obviously, if you push too hard, sometimes you can intussuscept a duct, or you can get into a false track or a false passage called via falsa. Remember this image, this fibrous things which can be seen is not inside the duct ever. If you see a blood vessel in your field, you are definitely outside the duct. So, these are two things that you have to remember. My gratitudes obviously to Professor Francis Marshall, who taught me sil endoscopy, Dr. Kirtane, as all of you know, He has not only been a professor, he has been a guide, a philosopher, a friend. I mean a person who would encourage, and I mean for no reason why I can see he is encouraging young people like us to go on the path that we have chosen. My family, without whom it would not have been possible to reach here, and these are a few of the other activities other than ENT and silent endoscopy that I do. Thank you.
Absolutely fabulous.
Thank you, sir.
Although, as he said, the picture quality did not match what Maruti showed us. Its reason is obvious. But even then, I think we saw very clearly what you wanted to show us. Very precise presentation. Questions, please. How many of you in the audience are doing salivary endoscopy?
Well, it's time that most of you pick up because there's a huge caseload. So remember, do this wonderful procedure. There's nothing in the surgical field which is more beautiful than removing an obstruction and getting those results. So for the stones as well as the strictures.
So let me ask this question, since there are no questions coming from you. Divya, for example, you work in an institution, you work attached. I am not trying to put you down, I'm just asking you, why is it that you haven't started salivary endoscopy? Let's try and understand, because there are enough number of patients. So, I mean, he's doing such a wonderful job. Why is it not something that's picking up? What are your reasons for not starting? Divya?
Sir, how much is the proportion of diagnostic endoscopy and therapeutic? What I mean by therapeutic is, when you did a scopy, patient was benefited later on.
Right. Let me put it this way. I never go in with the idea of doing a diagnostic silent endoscopy. Most of my diagnosis will happen on radiology, on MR silography, ultrasound, clinical examination history, and I have arrived at a conclusion. So if there is a stricture, I am going to go in and dilate. If there is a stone, I am going to go in and remove. If I fail to do so, then retrospectively I will label it as diagnostic. So I don't do diagnostic silent endoscopies, I do therapeutic silent endoscopies. So all my silent endoscopies are nearly therapeutic, maybe 1% in which I have failed, they turn out to be diagnostic.
Any other questions?
Can you pick that up pre-operatively?
Pick up what?
That there will be a stricture or there will be a stone?
Yeah, obviously. I mean, stones are very commonly diagnosed on ultrasound. If you find a stone on ultrasound, generally if you need further information, get a CT scan done. If you find no stone, but obviously why are you doing an ultrasound? Because the patient is symptomatic. So there is some obstruction. No stone generally means a stricture. So you do an MR silography.
I asked Divya a question, but anybody would like to answer that. Why people are not taking up? What do you feel is? Anyway, there are any questions, please? Yes. 1 minute. Dr. Jadhav.
How this setup can be started in private practice?
Right. You need to just get yourself trained, and then you just are on your way. We are here to guide you. So
what about the infrastructure?
I mean, the infrastructure is the scope and the specific silent endoscopy instruments. Rest all is the camera, light source, monitor.
That is common.
Yeah.
Any other questions?
Sir, the general feel or fear in practitioners is these scopes are very flimsy and they won't last you.
Okay, very good question. I always answer this with a question. How delicately do you take care of your car? So it's simple. This is a delicate scope, it costs, take care of it.
So my question is that are there dedicated training centers in Maharashtra where we can pick up this course, like we have IMAST or something? Yeah. Or do you have a fellowship course where we can come and learn with you?
Like he has been behind me and I have to tell him that I am in the process of building up a fellowship, but there are training centers, some training centers. In Maharashtra, we have one at IMAST.
Okay. In Mumbai?
In Mumbai.
Yeah. And there will be one soon in Nashik also. You're working on it.
Yeah.
Okay.
So then, it is observed that at least in Mumbai, none of the teaching hospitals are doing it actively, where we can refer our patients currently. I don't know if.
So that is the reason what I'm trying to find out. Why is it that it is not picking up?
So maybe the equipment is very costly and the break and wear and tear of
certainly
the
cost less than your car.
Yes, sir.
Definitely.
But sir, it costs more than.
So is
3
cost
lakhs.
cost one of the factors?
So in private, it is costing 3 to 4 lakhs per patient. I can give names and examples in Mumbai.
No, the thing is, the scopes are costly, but we are now getting not the scopes, but the other equipment is being manufactured in India, so we are reducing the cost. We are also in the process of trying to see if we can develop a scope this small. I have a person who says he can make it about 2 millimeters in diameter. We need to get it down to 1 millimeter.
So the consumables that you are using, are they covered by insurance?
Yes.
So if you have a patient who has to spend that money, if it is okayed by the insurance, then I think that factor may get negated. So the stents or the baskets that you use, they are expensive.
They are expensive, but we are we are making it in India. So,
yeah, but whatever the cost, when you bill it on insurance, the insurance companies are paying. Okay.
Yeah.
So do we have anybody here now who wants to start with silo-endoscopy? Because that was the whole purpose of this lecture.
Yeah, once the cost comes down, only then, with the hospitals would consider, because they would directly proportionate to the number of patients that you see. So the number of patients are not to that number that, the cost of the equipment can be covered, so they always see the economics of it.
Right. This has always been a topic, but I equate it with, say, suppose you are going to start a hotel or a restaurant. I mean, how many customers are going to come? You have to start and they come in. So you will have to convince your hospital administrator that, I mean, a waiting period of 3 years is fair enough.
Because
for return on investment.
Half the equipment you already have. You have a high-end camera, light source, you have the tower, you have the monitor, everything is there. You don't have to buy that anew. It's only the endoscope, which is expensive, which is delicate, which needs to be looked after.
Yeah. And training for that, because if it's a delicate thing. If you are not trained and you use it haphazardly, it's going to break. If you break it in your first 2 or 3 cases, you are never going to take up silo-endoscopy again.
So I personally feel it's a field that is open and should be looked at. And it's like today, why is he doing more cases? Because people know that he's doing it. So once you start something, automatically over a period of time, the references will increase. Yeah. Okay, now we have got about 15 minutes. We are caught in a bit of this thing because at 12 o'clock exactly, we have to log on to, so Nishan, what do you suggest now? The tea is coming around to you, right? So you don't have to get up, but for the next 15 minutes, anything that you would like to?
We'll give the break. And
don't give a break. Let everybody be in here, because coming after the break takes 10 minutes.
Sorry?
I have not got unedited because I have just got this talk. Yeah.
Gaurav's presentation is something different, so I don't think he can do it in a break.
Right.
Like
Yeah.
He can't do it in. Maruti, if you've got some videos of live surgery, नाही आणलेली तू. आहेत काही? का ते दाखवले सगळे तू? Okay.
Sir, I request you to please felicitate Dr. Shirish with the token of gratitude.
How scope last if handled well?
Sorry?
How many cases can one scope go on for?
Okay. The recommended from stores, the manufacturer of the scope, is they say if you can do 30 to 50, it's good enough. I'll tell you my experience. I have 3 scopes. I've done more than 650 cases. One of the scopes I am not able to use because the light carrying fibers have burnt. The optical fibers have not burnt, but that cannot be repaired. So it's as good as useless now. Yeah.
And what would be the cost of a scope?
The scope currently is around 6 lakhs. With the, if you generally start with one, you can start with one, and then as you progress maybe 10, 20 cases down the line, you can buy another one. The other equipment is around 4-5 lakh rupees. So in all, 10 to 12 lakh rupees is the initial investment.
So like nasal endoscopes, we have adult, pediatric and the angled. In silo endoscope, is it a single scope or there are 2-3 variants?
There are actually two basic types of scopes. One is called the modular, where you have just the optic element in a steel sheath.
Correct.
And then you put on operative sheets over that. So these are removable, lure locked sheets. So they are removable. So you can change the size of the instrument channel that you get. So these are called modular, but even in modular you have two sizes. Pediatric one is 0.75 millimeters in diameter and the adult is 1 millimeter in diameter. The other type of scopes is all in one, manufactured from the company, the instrument channel, irrigation channel and the optics all in one. So you cannot separate out all of them. They come in 3 sizes.
So apart from stores, are there any other good companies or only stores has that privilege?
So then let me ask Shirish this question. Suppose one of these people want to start off.
Right.
What would be the bare minimum necessary equipment they'll need to at least start the program?
Right. I would quote my example. I started, obviously financial constraints are always there. So I bought a pediatric modular scope because I said a pediatric scope can be used in an adult. An adult scope cannot be used in a pediatric case. So I started with a pediatric modular scope. That was one scope and instrument. So about 10 lakh rupees is the initial investment. And then sooner I realized that getting an adult scope will also be better because there are a lot of adult cases. So I bought another one.
Besides the scope, what else would there be?
What else is you require the irrigation channels, the sheets, then you require these guide wires, dilators, the specific forceps where you have to do combined approaches for stone removal, specific angled forceps. So that's all, and the sterilization set.
So cost-wise what?
10 lakhs. One scope and the instruments, silent endoscopy instrument would cost 10 lakhs.
So in your view, would a modular or all-in-one, which would be better to?
I prefer the modular one because it is more versatile. And when you begin, one scope can give you the advantage of nearly 2 or 3 scopes. If you change the sheath,
correct,
the instrument channel can be changed, right? So the optic element remains the same. The instrument channel size can be changed as we change the sheath. So some instruments pass through a wider channel, like a guide wire which is 0.6 millimeters, then there is a basket which is 0.8, a basket which can be 1.2, so you will have a larger channel through which you will have to introduce. There are also metallic forceps available, though I am not a fan of using them, but they require an instrument channel which is 1.7.
So it gives you more flexibility,
yes,
basically.
But it's a bit difficult to introduce as compared to the all-in-one.
I believe you are collaborating with somebody in developing these baskets, etc., to be made in India, which would become cheaper.
Yes.
Tell us something about that.
Yeah, this instrument manufacturer, fantastic fellow, he came to me once and then said what kind of equipment you are using, and then he said, and he comes back with a wonderfully working basket, and we are trying to improve on the design. So that is the stage where we are.
So baskets or the accessories could get cheaper. So you could use the short scope, but you could buy the locally made accessories which would make things cheaper. Is there something also regarding drilling into a stone? What is that? Can you tell us?
There are handheld burrs available. So they pass through the instrument channel and you can rotate them with your hand to break the stone. You can also, like Dr. V. Anand did it, he also put it onto our own mastoid handpiece, and then you can use it that. Though I have not been using it to break the stone because the idea is generally if you cannot remove it through a basket, purely silendoscopic approach, then you do a combined approach.
You have to work.
A bit, yeah.
And any role of lasers in breaking the stones?
Yes, lasers have been used, the holmium laser has been used, it is effective, but it is time consuming, sometimes it causes a lot of thermal damage to the duct, and quite a few of the persons who are using lasers have now shifted to combined approaches rather than keep on using the laser.
And When you say combined approaches, is it an external approach or within the?
Yeah, for the submandibular stones, it's like an internal combined approach. For the parotid, the distal part of the duct, you can approach internally, and for the proximal part of the duct, it's a combined approach.
And for large stones, is there, like we do it in kidney stones,
Right.
the lithotripsy?
Yes.
Do you have something like that to fragment the stones inside the duct?
Yes. We have no silolith lithotripser in India. There are about 2 in Germany, and the company has stopped producing them. They are hugely costly. They are ultrasound based, so there is another issue for us in India, because if you get that in, then you are under the PCPNDT Act. It's not very effective in the sense it takes around 4 to 6 sittings for the stone to be destroyed, and still you are not sure that all the fragments have come out. So it may be a needles for a further stone happening.
How do you treat traumatic parotid fistula?
Traumatic parotid fistula, the same way as the paratocele, you go in, find out the proximal end. You are going in from the distal end, you go in and find the proximal end, pass a stent over the guide wire, and that's the natural healing process. If you have the normal pathway open, the fistula will close.
How often do you have to open it up to remove the calculi?
It depends upon, sometimes it's the size, sometimes it's the location. So maybe I would guess around 50% of the times you can open it up, but you go into the proximal ductal system after the stone is removed, make sure there is no stricture there is no fragment inside. You pass in a guide wire, pass a stent over it, and close your incision. So you have the natural path flow path intact. No, ranulas are difficult. You generally do not find the sublingual duct opening. The basic pathology of the ranula is that the sublingual duct gets blocked. So you have to be able to cannulate that and open it up. So I have not been able to do a ranula treatment purely endoscopically.
Shirish, without discounting your expertise, why is siloendoscopy in India such a nascent field? Why it has not caught up? In Maharashtra we can take 2 names. Of course, you are number 1. Even other states, there are hardly few whom we can count on our fingertips. So why is it in such a nascent stage? Why it hasn't caught up like cochlear implant or
Right.
DCR or whatever?
Right. I think there are a few perceptions. One of them is there are not enough cases. Okay, so that is one perception. Then probably you are thinking about the economics, then you say that there are not enough cases, so my return on investment will not be good. The other thing is some people without training have tried to do it because it's a scopy kind of a thing. But they have broken scopes, and that has percolated that okay, the scope is very fragile. But if you do not use the protective cover, obviously it's fragile. The third thing I believe is you as ENT surgeons, we are always used to landmarks, especially bony landmarks. Any surgery that we do, endoscopic sinus surgery, mastoid, anything, we have bony landmarks. Here you have no landmarks. So we have to unlearn a little bit of our training and then relearn. So the learning curve is a bit longer, I would say. That's the only reason. But there's always joy in going on untrodden paths. So
my last question is, should oral and maxillofacial surgeons be trained and doing this, or is it a privilege that only ENT should enjoy?
There is no regulation against either of them doing it or not doing it.
Actually, I feel,
surgery, so you can't say.
Yeah, I think mainly the cost and the delicacy of the instrument, because I have done the fellowship in 2011. Since then, KEM is trying to get the silendoscope, but it is not coming, and even if it comes, like the wear and tear is very high. So that is what is the reason I think it is not picked up as cochlear implant.
Well, if you use it properly, I have done what 650 cases in 3 scopes. So I think that's
No,
enough.
I'm just talking about the big institutions
Yeah,
and
but,
the cost factors
but
in private practice
make
also.
sure. I mean, all the other equipment, you make sure that they are properly handled. Like when I was in college, asked to handle even mastoid drills very delicately.
Yes.
Because in those days they were difficult to procure.
Yes.
But I mean, times have changed. This will also change
but
over
I
a period of
think the
time.
cases are enough. It is not that the cases are less. The cases
Yeah, I think,
are
Neelam,
enough.
this is a question of which comes first, the chicken or the egg.
Yes, yes,
Should
sir.
you have more cases and then get the scope, or get the scope first, let people
Yes,
know
sir,
and the
yes,
cases
sir.
will come?
Absolutely.
Yeah.
Okay.
But I think in a municipal corporation hospital,
Yeah.
a budget of 10 lakhs is like
Yes.
Nothing.
It's nothing.
It's more of a mindset.
Yeah.
If
yeah.
you are convinced, you will be able to convince others.
Yes,
Without your conviction, you will not be able to convince the decision-making authorities to invest.
Right, right.
Anyway.
Good morning, sir.
Congratulations.
Sir, need to ask one question, sir. In case of adult onset or the juvenile onset parotitis, I want to know that what antibiotic you prefer and when you like to do the cystoscopy.
Well, conservatively, if you find that there is pus coming out through the duct, then only antibiotic plays a role. Otherwise, there is no role. It is most of the times an inflammatory process rather than an infective process. So, I have been using amoxicillin with clavulanic acid, I have been using clindamycin. So, these are the two antibiotics, if required, I use.
I think we are on to the next
Right.
session. Now we are trying to get Dr. Robert Vincent to join. Would say, wonderful session. Thank you.
Thank
very
you,
much.
sir. Thank you for your guidance. I mean, I would not have been standing here without you.
I think that Nasik Institute has to come very soon.
Right.
I've been trying to tell him that he has to have a training institute. I think once we can get the training, the fear of handling the scope
Right.
will go away.
Yeah, hello. Hi, sir. Good morning.
Good morning. How are you doing?
Yeah, good, good. Can you hear us?
Yes, I can hear you perfectly.
Thank you.
So we'll be beginning with Dr. Vincent's lecture. You can scan this QR code.
Pardon me?
Nothing, sir. Very good morning, sir.
Hello?
Am I audible to you, sir?
Yes, write it directly to.
Yes, sir. So, we are here, we are connecting you to the 10 multiple centers in India.
Okay.
We are here at Base Center, Mumbai. With us, our mentor, Dr. Milind Kirtane sir is also here. We are going to have a lecture which is going to be flashed across country with of course, 10 physical centers. After the end of your session, what we have done, we have actually have a chat box where all questions will come to us, and at the end of your session, Kirtane sir will moderate with the questions. So this is something the flow what we are going to have with you.
Yeah, Dr. Vincent, welcome, and we've been eagerly waiting for your talk. As he said, we are going to ask people to give in their questions in writing to us, and at the end of your session, we will have a discussion on whatever doubts or questions that the people have. So you're going to talk to us right now on the various aspects of stapes surgery. So the floor is yours. You could share your screen and start the lecture, please.
Okay, let me try to share first, and then I will say a few words for introduction. I think it's this one. Yeah, I guess you can hear me now, right? Can you hear me?
Hello.
Yes, sir, we
Yeah,
are
can
audible.
hear.
You can hear me, right?
Yes, sir.
Okay, good. I just want to start my presentation, but first of all, I just want to say some words about that. I'm very, very proud to be part of this fantastic event. I guess this is very impressive for me to see that I'm connected to so many centers in India. Of course, you know, I'm very connected to India. I have so many friends. And of course, one of the main one is Hashim, which is Hashim is one of my best friend. Is even more than this. Is one of my brother in India. I'm one of my brother in the world. Hashim is part of Hashim Desai is part of the faculty of the otology course of the course ear clinic. So this is really great for me to be there. So I will try to start my presentation. But first, again, thank you very much for inviting me to be part of this. And usually I come to India because I love to be there. I love your country. It's always a great time. But I'm also very happy to be connected to you. So we are going to talk about stapes surgery. So my plan is to first present the technique I'm using for basic stapes surgery. And then, of course, I will move to specific condition and difficult cases. First of all, what I want to say is that I'm going to show the technique I'm using in stapes surgery. And I'm not saying that my technique is the best one. That's important. It's just presenting and sharing what I'm doing and sharing my experience in this field of stapes surgery. And of course, I'm going to focus on otosclerosis surgery and not on tympanosclerosis, for example, which is another subject. So first, what I want to show you is the technique I'm using, which is the COS technique, which is the vein graft interposition and using a COS Teflon piston, using transcanal approach, which I think is important to explain first. I'm always doing transcanal and never endoral approach. And for me, I'm not using endoscopic surgery, but I know that more and more surgeons now are trying to do that. The reason why I prefer to use transcanal under microscope is that I want to have my both hands free and be able to expose all the landmarks. So this is a right here. So I'm going to show the entire technique itself, and then we will go back step by step using 3D pictures. So you can see here, this is the exposure I like to have. First of all, I have a speculum here with a speculum holder, and I like to see at least the posterior half of the tympanic membrane. This is right here, so this is 12 o'clock, 3 o'clock, 6, and 9 o'clock. So what I'm going to do now, I'm going to use a round knife and start my incision using this round knife running from 6 o'clock to 12 o'clock. You see that this little tip of this instrument, which is bent, allowing me to go into different angles. And again, you can see I'm using both hands. I'm using a suction tube with my left hand and a smooth elevator on my right hand, trying to follow horizontal line from, again, 6 to 12. It's important not to do straightforward central one because otherwise you can have a tear. And then I can see the annulus. And then once I see the annulus, I can open up the mucosa. And of course, you can see underneath the mucosa, we have this cord tympani. Now I use curette to do the bony rim resection. For me, bony rim resection is important because I want to have a clear exposure of two landmarks, which are very important for me. These are the facial nerve that you can see on the left one, on the left part, and the pyramidal process of the stapes tendon. And this is exactly what I like to have before doing anything on the stapes. This is a safe procedure, I think. So now I'm using a joint knife to do the bony rim resection. And you can see again with my left hand, I'm stabilizing the incus with a sucker. And I'm checking out the ossicular chain mobility. For me, it is important to separate incus from stapes before checking the ossicular chain mobility. And you see the stapes is fixed and malleus incus are mobile. Of course, I'm going to cut the tendon, the stapes tendon. And I'm using sometimes laser, sometimes not. Less and less laser, by the way. I'm using a micro drill with a 0.7 millimeter diameter diamond dust burr. in order to drill out the posterior crus and then the anterior crus. The anterior crus is more tricky sometimes because sometimes you cannot see clearly the anterior crus, which is thinner than the posterior one. But I don't like to break it. If I can, I always try to drill out. Then I can remove the superstructure, and now I can expose the foot plate, and I'm measuring now the distance from incus to foot plate using a Stapes measuring rod, which is running from 3.5 to 4.5. Now I'm going to perform the stapedotomy using again 0.7 millimeter diamond dustbur on my right hand and 0.7 millimeter diameter suction tube with my left hand, and I'm just leaving the diamond dust doing the job by itself. And you see also the use of this suction tube to try to control the fluid leakage over the Stapes foot plate. It's important to have, again, in my hand, both hands free, and you see the position of the sucker, which is not exactly at the level of the stapedotomy, but close to the stapedotomy, because of course, what I want to avoid is to have a dry labyrinth. So I'm opening up the perilymphatic membrane, and now it's fine, I'm happy about that. This creates something like a 0.8 millimeter diameter fenestra. And again, we have some residual perilymphatic membrane, which is not a problem for me, so I'm not going to remove that. I'm just now going to cover it with the vein graft. And of course, this is debatable. I'm using a vein graft as an interposition technique, which is, by the way, the COS technique with the vein graft in a position. The intima is facing the surgeon, while the adventitial side is facing the foot plate. And the aim of that is to seal the labyrinth. Now I'm using a COS piston, which is a 0.4 millimeter diameter Teflon piston, which I cut at a corresponding length. And I'm going to open up the loop, which is important to do. We need to break the memory of the Teflon, and I'm going to now introduce this prosthesis with the sucker to introduce the distal tip of the shaft within the stapedotomy, and then crimping the loop. We know that theoretically we have a memory with the Teflon, but it's important not to believe too much in the memory. You need to help the memory to close the loop, and then we look for the bending side, and that's exactly at the end what we have. I finish with the mirror cell, which is placed within the external auditory canal, and in my way of doing it, I remove the mirror cell on the 5th day, and we do the first very short-term post-op hearing test at day 6, mainly to rule out any complication in terms of bone connection. And then I see my patient after 3 months. Just a few words about the surgical way of doing it in terms of staff and instruments. You see the position I like to have for transcanal. My nurse is right in front of it, and I have the table with the instrument on my left hand in this case, where I can stabilize both hands. That's important for me. And I don't know if you can see it, but I have a speculum holder, which allows me to have a very stable position of my hands in order to place the left and right hand on the the platform which is created by the speculum. And I think it is important to have this stability. The vein graft preparation, I always take the vein at the beginning of the operation prior starting anything on the Stapes. The vein is taken from the dorsal face of the hand using a very small incision. And what I want to have is quite not too large, and trying to find a thin one. If it's too thick, then usually I press it to have a very thin one. So I take it like this, I'm going to cut it, and then I'm going to now pre-shape the vein, so you can see it's only one stitch. And then I'm going to remove the perivenous connective tissue from the lateral side of the vein, like this, with a knife. And in fact, now we are still facing the adventitial side of the vein, which is the sticky side, and this will go to the foot plate on the other side. The intima of the vein will face the surgeon. So this is, of course, too large. I'm going to cut a small part of this vein, and it's a good trick to keep the residual vein in order to For example, use it if you have any tear. So now we are facing the intima. I put it on a glass plate like this with a hole. It's a nice way to pre-shape the vein because I push the vein down into the hole, so the part round will stay wet while the external part will dry. Now, let's go back to step-by-step technique in terms of surgical technique of stapes surgery. So the first step for me is to have a clear exposure. So again, as I explained, we need to see the fascial nerve. This is the left ear, so we need to see the fascial nerve or fallopian canal on the right side and the pyramidal process. And what I like to do, if I want to check the osteocular chain mobility, I like to separate the incus from the stapes first, and then I will check the mobility first of the malleus incus and then of the stapes. What I want to do is to rule out, of course, any malleus ankylosis. And in fact, if you do not separate the malleus from the incus first, then you can, in my mind, I don't think we can make a diagnosis between stapes ankylosis and malleus ankylosis. So it's important to separate the joint first. So you see, I'm checking malleus incus mobility first, and then stapes mobility, and then using a needle like this, which is going to place on top of the head of a stapes. I'm not using a left-right mobility, but I'm checking an up and down mobility, which is more important, using a joint, a very fine needle like this. Now, of course, I'm going to cut the tendon, as you saw, which is a basic thing. And then I like to use laser, but to be honest with you, I'm not using any more laser now since more than 3 or 4 years. And in fact, it seems to me that I have better experience without using the laser if I compare my results prospectively. But anyway, that's another discussion. So I'm using in the past a combination of laser with handheld probe and microdrill. The first step is to vaporize the superstructure in order to decrease the thickness of the stapes superstructure to reduce the resistance of the superstructure. And then I'm just finishing the job by using a microdrill, 0.7 millimeter diamond Vesper, just like before, and I'm removing now the superstructure. The next step will be to measure, and I believe that's important. I know that some surgeons in Europe do not measure, and they always use a 4.5 millimeter precisional cases, which I don't think it's great because I'm using a database which is called ONDB, Otology Neurology Database, in which I put every information, including the distance I'm measuring from incus to foot plate. And it's true that in something like 75–80% of cases, the length that I have is 4.5. This is clear. But I also have cases of close to 5, sometimes even more. Very rarely, but I have that. And some cases less than 4. So I think measuring is important. Otherwise, there's always a risk of having a short prosthesis or long prosthesis. I'm using a stapes measuring rod. So I'm touching the foot plate, and I have 3 notches according to each length, 3.5, 4, 4.5. So I'm using a mid-surface of the incus. And the next step now is to perform a fenestra, again using combination of laser and microdrill. Again, starting to vaporize with the handed probe the foot plate. This is a CO2 laser. That was the OmniGuide system, which I moved then through other types of laser, always now a CO2 laser, which, as you know, is safer than any other type of laser because the CO2 is totally absorbed by the perineum. And you see that the beauty of the laser is that you decrease the resistance of the foot plate. This helps you to perform the fenestra more easily without any pressure on the foot plate. So just the preparation of the fenestra. And again, the vein graft, as I explained, we need to cut the vein like this, we are facing the intima of the vein, and you see I'm sticking the vein to the sucker. I'm using 0.9 millimeter diameter sucker at that stage. And then I'm introducing the vein with my left hand with the sucker and stretching the vein with the needle. I'm always taking my time to be sure that I'm going to stretch the vein correctly. In my experience, I had few cases of postoperative fistula when I was starting this technique a long time ago, unfortunately. And when I was able to revise these cases, which were personal failures, I found that, I think it was 8 cases in total. In all cases, when I revised them, I saw that the vein graft was not completely, perfectly stretched, and I had cases of anterior fistula, or fistula occurring from the anterior pole of the foot plate. So it's important to spend some time, if you want to do that, to stretch the vein. And I'm not saying that, again, vein graft is the best technique. I'm just saying what I'm doing. It's always a very debatable time with or without interposition. And I must say that I'm in favor of that because I just wanted to seal the labyrinth. It doesn't make, in fact, I don't think it makes any difference in terms of surgical outcomes. It doesn't make any sense for that, but the sense is to seal the labyrinth in my experience, in my mind. And then the next step to cut the prosthesis at the corresponding length, exactly at the right length, which means that if I measure, let's say 4.5, I will use a cutting block like this, and I put the stapes prosthesis at 4.5 hole, and I'm cutting it exactly at the corresponding length. I'm holding the shaft, and I want to break the memory of the loop of the piston with the needle. This is a 0.4 millimeter diameter Teflon shaft. That's important to break the memory, otherwise you cannot insert the loop around the incus. And now I'm going to introduce the prosthesis, and again, I'm using the sucker. I have a special system for the suction system, which is pedal with negative pressure, which means I'm using the suction system like a regular instrument, and I'm closing the loop with the 2 hooks. The left one here is used to prevent any protrusion of the prosthesis within the labyrinth, and the right side, the right hand is used to, the right hook is used to crimp the loop. And I'm looking for the bending sign, which is important. Then you can also use, of course, a curved forceps like this, but I prefer to use the two hooks. Now, the bending sign is important just to be sure that the prosthesis is located within the labyrinth, because of course the fenestra is hidden by the vein. So I just want to be sure that the length is fine and that the shaft is located within the fenestra. The piston should bend but not move. If the shaft is not within the labyrinth, within the fenestra, when you do this, the shaft is moving away from the fenestra. Now, that was the first part of my talk, which was the basics of stapes surgery. We're going to go now to what I call complications, which means preoperative complications and not postoperative. This is another debate. I'm talking about different presentation and surgical findings. The first one is the obliterative otosclerosis. Interestingly, in my experience, you know, more than 6,000 cases now last year, my incidence was 2.5%, but which is important is in terms of number, is the incidence in the pediatric series, which was rising up to close to 20%, which is, I think it's the most important thing to understand, that if we are planning to do stapes surgery on a young child, there is a higher risk of obliterative cases. So what is my technique? By the way, I'm going to use the same technique in terms of stapedotomy with vein graft, but the difference, as you will see, will be the way I am drilling out the foot plate. I'm not performing a straightforward stapedotomy. I am decreasing the whole thickness of the foot plate progressively in terms of having a flat foot plate at the end, decreasing the whole thickness of the foot plate. I think it's called like something like skeletonize the foot plate until I have a thin foot plate, and then I'm performing a stapedotomy. I'm going to go a little bit further to show you the way I am performing stapedotomies. This is the way I'm doing it, so you can see I am just using the diamond dust to drill out progressively the whole foot plate without any pressure, because we need to remember that this type of biscuit foot plate could be very fragile, and you can dislocate the whole foot plate. Like a biscuit foot plate like this would be a problem to have a floating foot plate. So it's important to just leave the diamond dust doing the job by itself and enlarging the drilling out procedure until the thickness of the foot plate is completely decreased, up to the blue line, which is of course the perilymphatic membrane. And then at the end of this procedure, only when I feel that I can see the blue line, I will start the fenestra in the same way. But I just wanted to focus on the way of drilling out the foot plate like this. Just again, leaving diamond of the visual by itself, and again using with my left hand the sucker. Measuring is important, but I'm measuring also at the end of the procedure, because we need to remember that we have a thick foot plate. So if we do not take into account the fact that the foot plate is very thick, if we only measure the distance at the beginning, then we missed out something, because it's going to be longer than this, and we can just cut the procedures too shortly if we do not measure at the end of a procedure. So that's an important point, to remember how to measure the distance. If we have a regular foot plate, I measure just after having removed the superstructure. But if we have an obliterative case, it is important to measure again at the end, because we can have sometimes 0.5 millimeter difference. So this is the end of the stapedidotomy, and this will be, of course, followed by vein graft deposition, which I'm not going to show again because you've seen that before. I just wanted to focus on the drilling out procedure. So again, you can see now the measuring at the end, and the vein graft and the piston again. Now the second type of complication that we can have is the facial nerve dehiscence. So what I like to do again is to get some exposure. You can see we have the left here. And what I want to do is to remove now the superstructure. Once we remove the superstructure, we have enough gap. And I'm using now the bucket handle prosthesis, which goes underneath the lenticular process, allowing me to be away from the facial nerve compared to the regular cos piston. So this is the left one. This is the left ear. We can see the dehiscent facial nerve, which can be much worse than this, because in this case we have some gap between the facial nerve, which is completely dehiscent, as you can see. Remember that the facial nerve is your friend. Once you have identified the problem, you can avoid having any problem. It's always the same thing. We need to have a clear exposure to be safe in our surgery, and then it's going to be fine. Now, the same thing will be with the vein graft, and then at the end, placing the prosthesis. So let's go. Now, once I have removed the superstructure, I have enough gap, but I need to increase the gap by doing the promontorial resection. So I'm drilling out the promontory. That's important. I do that with, again, the macro drill, and then remove the superstructure, and now we have a clear exposure. And now I can measure, but again, this is not safe enough. I just want to have a better exposure, so I need to increase the gap between the facial nerve and the promontory. So I do the promontorial drilling out procedure with, again, the laser to decrease the bleeding first, to vaporize the vessels, and then I'm going to drill out the promontory with the macro drill. And when it's done, when I think that it's safe, that I have a better gap, then I can perform the stapedidotomy only when it's a safe procedure, when my gap is good enough. It seems to me that I have some electric problem with my battery, so if there is any interruption, give me a few minutes just to link my computer again. So you can see the drilling out procedure of the promontory, and now I'm going to drill out the promontory like this. You need to be strictly perpendicular to the promontory in order to be fine. And it's good enough to do it to enlarge the gap. It's safe if we stay perpendicular to the promontory and not going into the conclave, of course. And once we have a clear exposure, then I will start performing the fenestra. Like this. It's getting better, and I'm doing, as you can see, I'm not doing anything on the stapes foot plate in terms of fenestra unless I have a clear exposure and safe exposure of the foot plate. So it's always the same technique, but a different way of measuring, using the foot type of prosthesis and drilling out of the promontory. The difference in terms of the choice of my prosthesis you can understand in this case, if I use a regular cost piston, that the shaft will be fine, will go into the fenestra. But then if I crimp the loop around the incus, there's a risk that the shaft will come into contact to the facial nerve, which in fact for Teflon prosthesis is not that major importance, but it's always safer, I think, to be away from the facial nerve. So I use the bucket handle prosthesis, which has a hollow head, which will go underneath the lenticular process, which means that we have a little bit of a distance, better than with the loop, which will be around the incus. The bucket handle will go underneath the lenticular process. So in fact, we'll be away from the facial nerve. But remember that if we use the bucket handle prosthesis, the handle, the head of the prosthesis, which is has a hollow head, will go underneath the lenticular process. So we need to take into account the thickness of the lenticular process, which is average 0.5 millimeter. So we need to take into account this difference, which means that I need to remove 0.5 millimeter to the length that I measured, which means that, for example, if we measure 4.5 millimeter from incus to foot plate, then I will, if I use a regular piston, I will cut it at 4.5. But if I use a bucket handle prosthesis, I will cut it at 4 millimeter. So that, I think it's fine. Now I'm going to go directly to the choice of the prosthesis to show you the way I'm using it. So this is again the vein graft, and this is the prosthesis with a hollow head, as you can see. And that's the same type of prosthesis with a Teflon shaft and a Teflon head with a loop, as you can see. And I'm cutting it at 4, which means that probably in this case I measured 4.5. So I'm gonna cut it in the same way, and then I will introduce the prosthesis with the sucker. So I'm going to hold the prosthesis with a sucker 0.9 millimeter diameter suction tube, and I will introduce the shaft first within the fenestra, and then I will easily, it's very easy procedure in fact to introduce the hollow head and the lenticular process. I'm rotating the prosthesis in order to place the anterior part of the prosthesis head right in front of the lenticular process, and then I will pull the incus to introduce the incus within the hollow head, like this. And then at the end, I'm going to place the loop over the incus, and to increase, of course, the stability of the prosthesis. In fact, I don't believe it's going to work more efficiently, but we have it, so we need to use it. And then, of course, looking for the bending sign is still important. So if you don't mind, I just move a little bit from that place to another one because I need to link my computer. It takes me a few seconds, so please hold on. Okay, sorry for that, but I think it was important to prepare that because otherwise I would have some problem. So you can see the difference, same technique, same way of measuring, but using a different prosthesis according to the situation. The other one would be malleus ankylosis. I'm talking about simultaneous malleus ankylosis, which is not the same as malleus epitympanic malleus ankylosis, which is a different diagnosis. I'm talking now about simultaneous malleus and stapes ankylosis. So I'm going to use, of course, a malleus to stapedotomy procedure and going to talk about the malleus relocation. Again, if you look to my series, the incidence of simultaneous malleus ankylosis in my general series is 0.6%, which is very rare. But again, if you look to my children's series, my pediatric cases, the incidence runs up to 4%, which means that there is, a high risk of complication with a young child. So I'm going to use a malleus to stapedotomy procedure, but I think it's important to point out the fact that in my mind, I think it is important to separate the incus from the stapes prior measuring or prior checking the ossicular chain mobility. What I mean is that if we have, I'm talking about epitympanic malleus ankylosis also in terms of differential diagnosis. If we have a epitympanic malleus ankylosis, which is, as you have to know, a congenital malformation and never related to ligament fixation, it's never been done like this, there's a kind of lever effect due to the malleus ankylosis. So if we do not separate the joint first, we cannot make a difference diagnosis because there is a false impression of stapes ankylosis due to the lever effect. So I think it is important to separate the joint. So let's go to the technique. This is a right hand, again, transcanal approach, as usual. So you see I'm using a joint knife again to separate incus from stapes, and I'm going to check now malleus incus mobility. You can see a very strongly fixed malleus and a fixed stapes. Again, from the top of the head of the stapes, the up and down movement is completely stopped, and you see very strongly fixed malleus. In this case, I'm going to use, of course, the malleus relocation technique, and I will have to remove the incus, but I always keep the incus in position because, in fact, the incus will give me some resistance. When we have a epitympanic malleus ankylosis, it's not that important because the malleus is strongly fixed. But if we have, for example, an eroded incus in terms of chronic otitis surgery, it's always better not to remove the incus first because the incus will help you to have better resistance. So the first part will be same as before. So I'm going to go directly to the next part, which is the malleus relocation technique. So the first step is to do an incision through the periosteum of the malleus like this with a fine needle. Because the point is to separate the malleus from the tympanic membrane. I need to separate the entire malleus, and not only the distal tip or the umbo, but the entire malleus should be completely separated from the tympanic membrane. So we need to go anterior to the malleus, elevating the entire tympanic membrane like this, including the umbo, which is more difficult sometimes, including also the short process of the malleus like this. Of course, there's always a risk of making a tear. If we follow the bone, the risk is very low, but if we make a tear, it's going to be a limited one, so we can use a residual vein graft to do this. You can see I'm checking the tympanic membrane here. Now I'm going to remove the incus with a rotating movement with a hook like this. And now we have this malleus, which is not here overlying the stapes footplate. And there's always a gap with a more or less anterior malleus between malleus and stapes. It's also important when you do osteoculoplasty from malleus to stapes end. So I need to enlarge the bony membrane resection because I'm going to do the malleus relocation, and I don't want to have a relocated malleus in contact with the bony wall. So I need to enlarge a little bit the bony membrane resection. I'm using a hook like this. Let me stop a little bit the video to understand that. This is the pose. I'm using a hook which is placed, as you can see, close to the neck of the malleus. Because if you put it close to the umbo, there's a risk of breaking the malleus. So it is important to make it close, to place the hook close to the neck, and on the other side, because I don't want to dislocate too much the malleus and having a loose malleus. You can see I'm using the sucker on the other side of the malleus to control the mobilization of the malleus. And I need to reach the resistance of the anterior tympanomalleal ligament. I've already cut the 10th tympanic tendon, of course, and I need then to overstretch the anterior ligament. We really need to overstretch the anterior ligament if you really want to relocate the malleus. If you don't do that, it's going to be coming back to the original position. Now, again, there is a tendency to see a relocated malleus medialized, so you need to stick the malleus back to the tympanic membrane like this prior measuring. Otherwise, there's a risk that you measure too shortly the distance from malleus to full plate. And that's an important point. If you have anterior malleus, you cannot measure like this. If you relocate the malleus to place it over stapes foot plate, then you can measure it in the same way as from incus to foot plate. But of course, I'm using an elongated stapes measuring rod, which is now running from 5 to 8 millimeter with 4 different notches. In this case, we have a fixed foot plate. So I just want to perform the stapedotomy in the same way, combination of laser and microdrill. You see the vaporization of the foot plate, and again, the vein graft. In this case, when you do malleus to stapedotomy procedure with the use of a torp, I think it is really mandatory to use any type of interposition. I always prefer vein graft, which is thinner than perichondrium, for example, fascia. But I mean, it's different when you do a regular piston from the incus. You don't really need an interposition. I agree with that, although I do it all the time. But with a chop like this, we need to avoid any protrusion of the prosthesis, and by using a vein graft, we decrease the risk. So this is a very nice prosthesis which I designed with Grace Medical, hydroxylapatite head, which means that you don't need to interpose a cartilage, and a 0.4 millimeter diameter Teflon shaft, which is going to be cut at the corresponding length. It's an easy way of cutting it. So it's the average length in my experience for this torp is 6.5, but it depends. We have some difference in somewhere, but in this case, for example, this is 6.5. And then the shaft will be introduced first, and then the prosthesis head will receive the malleus, which means there's no problem anymore with the malleus, because you can just pull the malleus and place the malleus within the groove. And you can see that I've designed this prosthesis according to this malleus relocation technique. So we have a groove which is located at the center of the prosthesis head. And you see at the end what we have is a final vertical position of the prosthesis, which is looking like this with a very nice position. And I'm looking, of course, for the round window sign, which I'm not looking for with a regular cost piston, but when I'm using a torp, I'm always looking for the round window sign, like this, which is fine, using a light to see that. And I'm taking my time to be sure that I'm placing it in a nice position. I'm looking for a final vertical position of the prosthesis like this. You can see we need to be sure that the length is fine and that the prosthesis head is touching the foot plate. We can also use a malleus piston like this, making a small, in this case I'm not going to separate the malleus entirely from the tympanic membrane, just making a little hole, a gap between the tympanic membrane and malleus central, and closing it like this. But to be honest, in my experience, I don't like to do that, because I have cases where the Teflon was not very well tolerated by the tympanic membrane, and I had some cases of reaction of the tympanic membrane, which could move to a necrosis of the neck of the malleus, which was a point will be a complication of a floating foot plate. I'm going to do very shortly, because in my mind, a floating foot plate is not a problem. It means when you are drilling out the foot plate, if you dislocate the foot plate and you have a mobile foot plate like this, my vision is that we do not need to remove the foot plate. If we try to remove the foot plate, it's more tricky and more dangerous. And the second point is that we don't need to remove it because it's a mobile foot plate. So we just need to cover it with the vein. And then I use a piston from incus to foot plate, just like having a dislocated stapes superstructure, for example, traumatic dislocation of the foot plate. So I'm putting the piston like this. I like to use a vein graft to protect the foot plate, because if you mobilize the foot plate, there's always a risk of a fluid leakage. So I prefer to use a vein graft. For example, this is a left ear, and this is not otosclerosis. This is a case of traumatic dislocation of the stapes superstructure following head trauma. In all cases, all of you will never do stapedotomy in this case. We just use the fact that the stapes is mobile and put a prosthesis from the incus to the mobile foot plate. And I think it's the same thing if you mobilize the foot plate, because we have a mobile foot plate, so we don't need to remove it. So this is a dislocated distal tip of the stapes superstructure, as you can see. And then in this case, the foot plate will remain mobile. So when you go directly to the position of the prosthesis itself, at the beginning it's the same, then we check the mobility. That's a tricky situation, in fact, in terms of making a clear, perfect, accurate determination of the length of the prosthesis, because if it's too long, it's going to fix the foot plate, it's not going to work, and if it's too short, of course, it's not going to work. If you do a stapedotomy, it's easy, because of course, we always have something like 0.5 millimeter to be sure that it will be within the fenestra, but if you don't have a fenestra, you need to be very accurate. And then that's the same thing, same preparation of the prosthesis, and then placing the distal tip of the shaft in contact with the foot plate, and then the loop around the incus like this, closing up the loop to ensure, again, prosthesis stability. And you see that I place this distal tip of the shaft at the posterior part of the foot plate, because I always try to find a place on the full plate which is a little bit more stable in terms of having a little bit of a groove like this, like in this case, to have a better stability of the shaft of the prosthesis. And again, I'm looking for this mobility. You can see that now we have a nice mobility of the full plate with the piston. The second problem would be a perinephritic gusher. This is very rare because we are talking about a real gusher, which means that once you perform stapedotomy, even the beginning of a fenestra, you have a full pressure and you have the feeling that the whole perinephritic fluid is coming out of the speculum, which sometimes can be the case, and it's very frightening. What I would say, and especially to the young surgeon who still do not have any enough experience in this, remember that sometimes even if you have for a CT scan, you cannot predict having a gusher in all cases. And you have to remember that there's no risk. That's important. You will be under pressure for sure, but remember that you have time to do it perfectly and to take your time. So you don't need to rush, because if you rush, that's going to be dangerous for the patient. So just suck with a suction tube, take your time, unless you decrease your pressure, decrease your blood pressure, and decrease a little bit of your stress. Once you are ready, then you have to do it very fast. Put the vein, put the prosthesis, and crimp the prosthesis around the incus. And again, interposition in this case is of major importance. This is not a real gusher, because I didn't have for some time. The incidence is 1 per 1,000, so it's pretty rare, but it can happen. This is just a high pressure, but I'm using the same technique. So I'm going to place the vein, but of course, if it's a real gusher, you need to be faster than this. But again, the vein will decrease a little bit the gusher, but if it's a real gusher, it's not like this. The pressure will push the vein up. So what I'm doing, I'm just placing the prosthesis, and I'm going to keep the vein down by using gel foam like this. This is a trick to hold on the vein in good position to decrease the fluid leakage. And in fact, in my experience, before placing the gel foam, you still have the pressure like this and the fluid coming up. But if you fill completely the upper window with gel foam like this, it will hold the vein graft in good position, decreasing the fluid leakage like this. And you need to rise up the level of fascial nerve if you want to be very efficient like this. That's the end. Now, the other discussion would be a differential diagnosis, which means congenital malformation. I just want to finish my presentation like this. This is the left ear. And the message that I want to say to young surgeons specifically, I know that today I have lots of experienced surgeons connected with me in India, which they're all great one. I know all of them. They don't need any explanation. But for young surgeons, I think it is interesting. Remember one thing: if you are doing stapes surgery, and if at any time you have a feeling that something is wrong in terms of anatomy, it means there is a there's a trap, there's a risk of trap, and you have to be very cautious and keep on going on. But first, find your landmarks, which means the fascial nerve, the promontory, the round window, all these things to identify the position of the fascial nerve. This is the left ear. You see there is no connection, hold on, there is no connection in this case. That's important. Remember that if you find that, there is always a trap in my experience. It's not traumatic dislocation of the stapes, it's a congenital malformation without any connection from the stapes superstructure to the foot plate, which is fixed. In all these cases, when I found that, there is always a problem with the fascial nerve, as you will see, because this is the left ear. Remember, the fallopian canal is there, but there is a fascial nerve running along the promontory on the other side, which in this case, we have a duplicated fascial nerve. So that's, of course, very tricky because there's risk of fascial palsy. In this case, again, once you have identified the problem, you can hold on and you can keep going on and you can do a safe surgery in the same procedure. In these cases, we have a foot plate which is completely different, much thicker than usual. So you need to do it very gently. It's like a hard bone. So what I like to do is to use saline solution to decrease the heating until I reach the perilymphatic membrane, like this, and then at the end, I use again the same technique with the piston from incus to stapedon with the vein graft. This is another case where you can see, you can identify the problem more easily here because you have the facial nerve here on the left here running through the stapes superstructure. And interestingly, in this case, we have this facial nerve also passing through the stapes full plate. And again, same situation, same presentation. The distal tip of the stapes superstructure is not connected to the full plate. You see, again, a congenital non-attachment to the superstructure of the superstructure to the full plate. And in this case, there is a very big trap, but it's more easy than the previous one because you can clearly identify the facial nerve running up. But you can still doing, if you're an experienced surgeon, you can still doing stapedotomy in this case because again, here you see we have small gap between the fallopian canal and the superstructure. So we have enough gap to perform safe stapedotomy. So I'm not going to remove the superstructure here because it's connected and adherent to the facial nerve, but I'm just performing stapedotomy, keeping the superstructure in position, and then at the end, again, same thing, vein graft in the position, measuring, and the piston. So you see, you can do that. And just to end my presentation, because again, this is not the last one, but there's a case of persistent staphylococcus artery. The only message I just want to say is do not try to coagulate a vessel like this because there's always a risk of facial palsy if you do that and you cannot really coagulate it. But again, this is safe. Once you have identified the trick, the trap, then you can avoid the problem. So again, here you have to make the decision. It's always a decision-making problem. Do you have enough gap between the vessel and the posterior part of the full plate to perform safe stapedotomy? This is the case. We have a gap, so I can do it. If you do not have a gap, same with the facial nerve. Sometimes the facial nerve is covering completely the full plate, so there's no way to do it. But in this case, you see, you can do it, preserving, again, the staphylococcus artery. And again, at the end, I will put the prosthesis like this from the incus to the fenestra, avoiding and preserving the staphylococcus artery. So that's, I don't need to go to the surgical results, which I think is not so interesting. I just wanted to focus on the techniques. So maybe now we can go to question if you want. Thank you for watching. I hope you enjoyed that. It was just focusing on surgical techniques. And again, as I said, I'm not saying that's the best technique. It's just the techniques I'm using. And I know that there are different types of techniques. All of them are good once you have good results. Thanks very much.
Thank you very much, Professor, for such an enlightening presentation. Incidentally, your brother Ashim is now with us in the auditorium.
I can see my brother. Hello, Ashim.
Hey, how are you? So,
I'm always good if I see you.
Thank you. So I know that you're having a wonderful festival in Masog.
Yeah.
So
you've been there. You've been there to this.
Yes, and I'm glad you're sober enough to give this talk today. So that's great.
Last time you came, you had a microphone like this, but you were singing just like American singer. I remember that. You remember that?
Sinatra, My Way.
So we didn't know that Ashim sang. So next time we're going to get him to sing for us.
Yeah, he's really good. I tell you, he's really good. You have to do it again.
Okay. He's also got a presentation a little later on the facial nerve. So there are some, we've got people sitting in 10 different locations listening to you. Plus there are quite a few watching you on the online. So they've sent in some questions. In high pressure Grusher, have you reviewed the radiology later on to find out if there was an anomaly and what anomalies did you find?
Yeah, you can see that in some cases preoperatively, but not always. Sometimes you have a perfect situation with a normal CT scan without any enlarging aqueduct or something like that. And you can have a Gusher surprisingly. So there's no perfect way to prevent the discovering of the Gusher. So, but sometimes you can, of course.
And when you have this Gusher, I mean, it's a panic situation when you suddenly have CSF coming at you. So what do you suggest? You just keep on waiting till the pressure goes down, or do you try to stem the flow a little bit with a little cover so that the rushing is not too fast? Would you?
Yes, that's exactly what I mean. Don't rush, because in fact, in my experience, these types of situation and cases are not dangerous. I mean, they are resistant. It's interesting. And I discussed this point with all my friends all over the world, including Hashim, and all of them say the same thing. It seems that this type of ears are not so fragile, and we have time to do it. It's more dangerous if we do it, if we want to do it too quickly. The danger is there. So take your time, decrease your pressure. Sometimes you have to wait something like 15, 20 minutes. It's not a problem. You can control that and then put the prosthesis at the end.
And is there a higher chance of sensory neural deafness?
No, not at all. In my experience, it's interesting to see that.
There is one more question from Bangalore. I have a patient 2 months after surgery, the patient has developed tinnitus and slight amount of giddiness, feels the ear is blocked. The hearing is okay. So what would one do?
You know, it's a case-by-case discussion. It's always difficult to have a clear answer to this type of situation. It's difficult. We need to focus not on tinnitus, because tinnitus, unfortunately, there's no way to deal with this. To decrease that, we need to focus on dizziness. In fact, the point is, the question in our mind is to determine whether or not we're going to do a revision stapes surgery. Usually I don't like to do it immediately. I need to wait. But it depends on the type of dizziness that we have. In my experience, first, it's different if we have immediate post-op dizziness or delayed dizziness. The immediate post-op dizziness is usually not so severe, and because it's a mechanical reaction of the inner ear. On the other side, when we have a delayed, like after a few days, my experience is not good. So sometimes we have to make a decision, but it really depends on the type of dizziness. If it's a positional dizziness, like in many cases, or when he's sneezing or something like that, usually we can wait. But if you pressure the tragus and then the patient is having dizziness, you can feel that there's a fistula, so you have to go back. Fluctuating hearing loss, you have to go back. But if you can, wait a little bit, at least few months before making a decision, because when you revise immediately with a lot of blood, and it's tricky.
Robert, do you do vestibular head impulse testing in such cases with persistent?
Yes, you can do that. Yeah. Do you do it, Hashim? You do it?
If it's persistent, yes. If it's done somewhere else, yes, because mostly it's due to a longer piston. You know, with the hanging test and bending test, we don't have a long piston, but typically sometimes this can be due to a long piston. What's your opinion on that?
I agree with that. Same thing. And if it's a long piston, sometimes you can wait, because sometimes it's disappearing with some time, but not always. And then you have to revise. If it's continuing with a fistula sign, then you have to do the revision, of course. Yeah.
Okay, there's one more question from Guwahati, from Assam. Do you do a HRCT temporal bone in all cases?
Yes, because it is mandatory now in France. So it's a medical legal issue. If we don't make it and if we have a complication, then you have been in trouble. So we have to do it before. In many cases, it doesn't help, because sometimes you don't see anything, and there is otosclerosis. You don't see always the complication. You don't see always malus ankylosis. But the main aim here is to rule out preoperatively any suprasymmetrical adhesions. That's the main point.
Okay. What are your criteria? There's a question here from the audience. What are your criteria for selection of patients for stapedectomy in children?
That's interesting. Children, there's a lot of things to discuss about that. The main point is to make a decision of operating. It's again a case-by-case discussion. If we have a child who is happy with a hearing aid, it's always better to wait until something like 18, 20-year-old. In that time, he will be able to make a decision by himself, and you can wait. But there are cases where the child doesn't like hearing aid, is having, let's say, 40 decibel hearing loss both sides, 50%, and he doesn't want to wear hearing aid, so he's having trouble at school. So then you have to do something. That's the main criteria, of course. And the second one for me, and the second one is, of course, the airborne gap, but that's like the general population. I'm always waiting for something like 25, 30 dB airborne gap. But if you can, with a young child, it's always better to wait a little bit.
So what is the earliest age that you've got otosclerotic in children?
not congenital. Otosclerosis, I think, was the youngest one is 8-year-old.
And confirmed autosclerosis. That's
Yes, confirmed. Yeah. I'm not talking about congenital malformation. That's another subject, but it's very rare. I think, but I don't remember exactly, but in my mind, I think over up to 6,000 plus cases, the incidence of juvenile autosclerosis is something like 45 cases only, something like that. So it's very rare, very rare.
okay. There's another question on tinnitus, that if you have very early autosclerosis and tinnitus, any suggestions on treatment?
Well, I think you have to explain. The most important thing is to explain to the patient that there is a low chance of decreasing the tinnitus by doing surgery, which is not, in fact, true, because it depends on the type of tinnitus. If you have a low-tone tinnitus, it's a better case in terms of decreasing post-operatively the importance of the tinnitus, the severity, compared to a high-pitched tinnitus, which is usually not working well with the operation. But also it's interesting to see that by improving improving the hearing threshold, we can decrease the importance of the tinnitus. But it's not always the case. So it is important that we need to take that to the patient first.
Yeah, because how would you counsel such a patient to ask you, okay, we're talking about hearing, what about the tinnitus? What would you usually tell the patient? Yeah, what do you say to the patient?
I tell him, remember that we make a decision for the hearing, the hearing, and it should work in the vast majority of cases, which is fine. But the tinnitus, I'm not sure. It can decrease, but it's not sure. So please remember that we make a decision only for the hearing. I try to insist on this point. Okay.
And there's one more question, I think rather quite basic. When you measure the length, are you measuring from the undersurface of the...
No, I'm using the mid-surface of the incus, because I just want to be sure about the length. If you use the undersurface, there's a risk of making a short prosthesis. So I always add a little bit, so I'm measuring, I use the mid-surface of the
incus, not the undersurface, okay?
No, the mid-surface.
One more question, when you have a unilateral autosclerosis with the other side having sensory neural loss, would you still do the stapedectomy in the sense?
But again, this is the case-by-case discussion. If it's a dead ear, theoretically, opposite ear is dead ear, which means you have a unique hearing ear. Theoretically, it's a contraindication for surgery, as we know. But again, there is cases where the patient wants to be operated, is suffering. To be honest with you, I have few cases where I had to do it on a unique hearing ear. And it's a long-term decision making with the patient, long discussion. You need to be in good condition and you need to trust the patient with that before making a decision. And it happened to me that I had to do it and it works fine. He was happy with that and the patient was happy. But it's tricky, because in terms of medical legally, I'm sure it's the same in India. If you have a complication on a unique hearing ear, then there's a problem to discuss that post-operatively. If you lose the ear and if you have a dead ear, could be a problem. But again, this is our duty to make something to the patient, and we have to take some risk sometime according to the decision making with the patient.
One more question here is, at times patient gets a sensory neural loss after surgery in spite of the fact that he's not suffered or has no reaction like a labyrinthitis or severe vertigo. Everything has gone smoothly, and maybe a month or 6 months later, 6 weeks later, when you do the audiogram, you find sensory neural deafness. Any comments?
This happened before. We're always facing that. And as you know, we should say that the French surgeon never have any complication. Unfortunately, it's not true. Not that. And we have cases, of course, of dead ear. I have case of dead ear. My incidence is 0.5% on the overall population. And sometimes, as you said, everything went smoothly. There was no problem on the surgery, and you have a dead ear when you remove the plug. And there's no way to deal with this.
No, but
and
what would be the probable cause? I mean,
I don't know. I really don't know. It's probably, I'm not talking when you have a bad situation, making some trouble with the foot plate, but if everything went smoothly, probably it's malposition of the saccule and when you open up the foot plate, you create a trauma to the sacral. I think, but I'm not sure about that. We don't know exactly.
What is your post-operative protocol, medication after surgery? What medication do you give?
Yeah, I don't use any more antibiotic as I did before. I'm using a straight dose of steroids during the operation, and that's it. I don't use anything else.
No post-operative steroids?
No, and then I remove the plug on the 5th day, and then I check the bone conduction before the patient goes out, and then I ask them to come back after 3 months.
Okay.
And maybe you can say I'm asking them not to fly for 1 month and not to dive for 1 month and things like that, you know. But
after that, is scuba diving allowed?
Yes. Well, it's interesting. If I always say if you can avoid that, it's always better. But I had cases where a professional diver, and we have to make a decision on that. And I ask them if you want to really do it, and if you cannot avoid, if you have to do it in the future, just wait 1 year. And by the way, I think in these cases the vein graft will help because the vein will protect the more efficiently.
Because we are getting more and more patients in India now, not patients, but people doing scuba diving. And one of the common questions we get asked is that, about that and yoga. Is these two things that we get asked.
Yeah. Well, I think yoga would not be a problem if they wait 1 month in terms of position of the head.
Yeah.
It's not a major problem.
Yeah. It's one position of the head that we tell them to avoid is upside down, when the head is down and the legs are up.
Sure.
I've got Ashim with me here. So Ashim, any more questions or comments, please, to conclude the session?
No, but I think he's not been introduced, so I'd like to introduce Robert. So Robert Vincent is instrumental in bringing middle ear surgery in a tiny little village in the south of France to preeminence in the entire world. And at least to my eyes, I feel that Robert is one of the finest middle ear surgeons in the planet. And I know that if I had otosclerosis, I'd go to Robert, and I like to think that if he had otosclerosis, he'd like to come to me.
I invite you again, Ashley. Don't worry.
No. So it's we share a long relationship, and there is so much to be learned from Robert. And I need everybody who's listening in on to know that he is a die-hard Indophile. He loves India. So much so that we can, in jest, I call him an honorary Indian. And he has a real affection for India, so he's been very busy the last few days because of a music festival that he organizes in the south of France, and yet he was kind enough to agree because he loves to communicate with India. So thank you very much, Robert. Really appreciate everything that you're doing for all of us, and it's always a pleasure to learn from you.
Thank you very much. Sorry, please go ahead.
No, please. I will just say to you.
No, you have to excuse us for using your English name like Robert and not Robert as...
well, I think it sounds better, it sounds better Robert than Robert, which I prefer Robert. So
okay. Just one question came to mind. I mean, we've been seeing otosclerosis for half a century now, and always we used to ask for family history, and I remember in my residency days that most of the time we would get a positive family history. And most of our patients would have bilateral otosclerosis sooner or later. And now I find patients coming who very often have unilateral otosclerosis, confirmed at surgery as well. And there is absolutely no family history. I mean, this changing pattern is what we've noticed. So
I agree. I have the same feeling. It's interesting to see that. Probably because we do better exams before, as we did before. More often, so we determine, something like that.
So the question that comes now is, the insurance company sends you a note. Please tell us the etiology of the condition, because before they settle the claim, they want to know the etiology. So what sort of an answer would be given this?
I will always talk about otosclerosis, saying that my diagnosis is otosclerosis.
No, the etiology of the, whether it's hereditary or whether,
Oh, yes, of course. I say heritage, always.
Hereditary.
Even if we don't have any family history that we know, I'm going up to this same direction.
Okay, so once again, a big thank you from all of us. As you can see, the number of centers that are listening into your press live.
I'm very impressed. But let me give you some words, because I think I'm very proud to be part of this, to see so many people watching to me. And Ashim was very nice saying that you're learning from me. I don't think you learn from me because I've been there many times. I've been doing surgery in India. I've seen you operating, and you have lots of very good surgeons. And it's just, for me, I have nothing to present you more than what you know, because you have a very experienced country in terms of fine middle ear surgery. And my main aim when I go to India, when I participate to meetings like this, virtually or by presence, is just sharing humanity. That's what I must say. Just sharing things, sharing friendship. And of course, Ashim is a special example for me. But that's the most important thing, just meeting people and sharing things, talking about complication, talking about life. And that's, medicine gives us the possibility to speak the same language and to make bridge over divisions, because our world is making lots of divisions more and more,
Unfortunately, yes.
complicated for our children. And we have the chance to, like music, to speak the same language. We speak about medicine, and that's the way to link people together. And that's a good point for me, and I'm very happy about that. Thank you again.
Thank you very much, and would just like you to know one thing. The Indian Society of Otology has a travel fellowship.
Yeah.
And almost everybody who gets the travel fellowship has only one center that they want to go to. And that's to go to Robert Wilson. So that tells you how popular you are in the country, how much the people love you here. So we hope to see you again soon.
But
Sorry?
you know why? It's because we have a really good red wine, as Ashim knows, in the south of France. So they are also coming for the red wine in south of France.
Okay. No, I think you're being very humble, but your popularity here, like everybody wanting to come to you, should really, tell you how much we love you. Thank you so much once again.
Thank you.
Bye.
Bye-bye.
Thank you once again. Thank you very much, Rupert. It's a pleasure. It's a joy. Bye.
Thank you. I think.
Yes. So I request our next speaker, Dr. Gaurav Medikari sir from Bangalore, to please have your talk.
So yes, I think now we can break for a lunch and.
Please, please, sir.
वहाँ पर कहीं और
Just mute from the other centers.
कुछ नहीं आगे हाँ क्या हुआ Abhi? Yes, ready. Can we start? Shall we start, sir? Yes. Yeah. So, first of all, thank you so much, Alkem and Kirtani sir, for giving me this wonderful opportunity to present at such an esteemed audience. There's some issue with the display. If we can get that fixed. इधर स्लाइड शो नहीं हो रहा है. प्रेजेंटर व्यू नहीं चाहिए वैसे भी. अभी कर दीजिए. Windows F5. अब आ गया. हाँ
HD में डायरेक्टली HD
इस तरफ HDMI डाल के देखो यहाँ पे इसको लगा दो ये डायरेक्ट
अरविंद डायरेक्टली आया
कंपैटिबिलिटी
यहाँ पे कुछ लेक्चर है
आ गया
डिस्प्ले का बनना है
साइज देखो प्रेजेंटेशन का दूसरे लैपटॉप में लेके
नहीं इसमें सबका वीडियो है बहुत सारा एक मिनट दूसरे लैपटॉप में नहीं डाल सकते अरविंद आया आया
एक काम करते हैं एक पेन ड्राइव पे लेके ना इसको
I will do that 100%. छोड़ दो मुझे 2 सेकंड ले लिया स्टैंड पे दिख रहा है देख दिख रहा है अरविंद ये डालना
आ गया चेंज इधर ये नहीं जा रहा है ना लेकिन
ऐसे करो ऐसे ऐसे ही पे रहने दो
हाँ ठीक है इसमें वीडियो ये कर सकते हैं
हाँ
क्या?
बस कर सकते हैं अब देख लीजिए वीडियो कर सकते हैं इस वर्किंग आ रहा है छोड़िए
आ रहा है नहीं आ रहा है ना
दोनों केबल लगा है एक मिनट छोड़िए डिस्प्ले सेटिंग अब आया वीडियो आ रहा है
आ रहा है अभी इस पे डालो Thank you so much for your patience. Sorry about the technical glitch that we had. So today I want to talk to you about the different aspects of what we experience when a patient undergoes revisions in endoscopic skull-base surgery. So for those of you who don't know me, my name is Dr. Gaurav Medikari and I'm based out of Bangalore. So this is a disclaimer that I want to present to all of you. So my presentation is not meant to criticize anyone. The point that I want to make is what are the kind of challenges that patients face and what surgeons face, the ones who are going to do the revision surgery, what they face. And I also want to raise awareness about the complexities of the procedures itself and what a patient entails when they go through these revisions. I also want you to kind of understand and foster the understanding and respect that this field of skull base surgery actually demands, so that we understand the complexity, and hereforth we at least do certain things to avoid these kind of revisions. So my data is based out of 90 patients who underwent revision skull base surgery in the past 2 years, out of a total pool of approximately 300 patients. So that makes it a ratio of about 1:3, or 30% of the patients that I did were all revisions. The most common cause for revision that I found was actually suboptimal tumor resection, which contributed to a whopping 66% of these patients had suboptimal tumor resections where they had recurrence or regrowth of tumor, which was found on subsequent imaging or by means of patient symptoms. The second most common reason that I had where I had to go in for a revision was inadequate reconstruction, followed by sinus outflow obstruction and bleeding. Most common sinus to be involved was actually the frontal sinus, which got obstructed. So out of the total number of surgeries, so we've categorized these patients into 3 groups. Those patients who had 1 surgery previously and I was the second surgeon operating, which was about 74% of the cases. In about 17% of the cases, I was the third person operating, and in about 9% of the cases, it was more than 3 surgeries. The maximum number of surgeries that any patient in my series has undergone is 10 surgeries, wherein I was the 10th person operating on this case. So what are the factors which affect cost escalation in revision surgeries? The first thing is the number of surgeries that the patient is undergoing. Obviously, every surgery costs a certain amount of money. Second is the complexity of the procedure, because the longer the surgery takes, the more complex it is, the more the bill is going to be. Third is the consumables such as debrider, coblator, high speed burst, transnasal burst, which are also very expensive. These also add to the cost of surgery. Increased length of stay, especially in skull base surgery. So if you also do a depression score, we have a PHQ score which we used, and you can obviously see very clearly as per the graph that those patients who undergone more surgeries were in more severe depression when compared to those who had lesser number of surgeries. So this also takes a toll on their mental health. Quality of life scores, I have data for up to 6 months in about 79 patients out of the 90 patients, but my 12-month data is a little weak at this point of time because we are still following up those patients, and I have only about 17 patients data, so I am not going to talk about it. So for the quality of life score in anterior skull base surgery, we use something called as the skull base inventory. This is a questionnaire, and what we found, this is the way you actually validate the response. It's a slightly complex mechanism of validating it, but it's a wonderful inventory to assess what is the quality of life of these patients. And if you compare this data, what you had, the quality of life scores that we had, you can see in the first table that the primary patients who are undergoing primary surgery before and after, there is a massive improvement in the quality of life. Whereas if you take those patients who underwent radiation when compared to primary cases, the quality of life improvement is not as good, because the second scoring we took at 6 months after the surgery. And if you compare those who had revision with radiation or revision, the scores are much worse when compared to primary surgeries. So this indicates that revision surgery itself is a poor quality of life indicator. Malignant histology as well as radiation, these were also found to have poor quality of life. So just coming to what are the modalities of imaging and how we pick up these incomplete resections or subtotal resections. One is CT scan, MRI and PET scan. Okay, so just to brief you about what we all know about these things, but just a refresher. So CT scan we use to understand whether there is any erosion of bone. You want to know what is the degree of aeration of the sphenoid and other sinuses, location and presence of sinus septae, especially near the ICA if there is erosion, or on the cavernous sinus if there is an ONOD, and what is the relation of tumor with the ethmoid or entire skull base for that matter. Whereas MRI is better to figure out what is the integrity of the medial orbital wall, the orbital muscles, if there is dural erosion or not, what is the character of soft tissue, especially near a bony erosion, whether it is actual soft tissue or whether it is fluid collection. You also want to know if the patient has already had certain iatrogenic injuries like a carotid pseudoaneurysm or optic nerve injury or a muscle detachment. And most importantly, what I find is that when you do a T1 fat sat image, you will also get to know the difference between whether the surgeon's fat graft is in place or there is actual fat disintegration or tumor which is present there. So the first case that I want to show you is this is the second time revision that I have done. This is a neuroendocrine tumor, and as you can see, there is a 360-degree encasement of both carotids here. So what we also found in our data is that the more posterior the tumor went, the higher the number of revisions, because most surgeons do not want to address these pathologies. So here we start off by doing I am going to show you about 3 or 4 cases, all revisions. So here we did a posterior septectomy. Surprisingly, this had not been done in the previous surgery, and majoritarily only the ethmoidal disease had been addressed here. So, the sphenoidal disease and beyond had not been addressed in this case. And as you can see, so the septectomy, once it was completed, we completed even the ethmoidectomy. We found out that it was not absolutely complete, especially the posterior ethmoidal group of cells had not been completely removed. What you are looking at is a 70-degree view of the frontal sinus there. We have actually completely cleared the frontal sinus, and now we are drilling over the lamina papracia to make sure that we do not have any of the ethmoidal septations left behind. So, once we drill out and we expose the entire skull base, then we get good landmarks as to where we need to go. So, you trace the skull base backwards, that is the neuroendocrine tumor which is sitting inside the sphenoid sinus. And after removing this the tumor, what we here, mind you that we have 360-degree encasement of the carotid. So, here we had to go almost 360, I would say. This is around 310 degree or 320 degree encasement, and here we are drilling out all the sphenoidal septations as well, removing the sphenoid mucosa which has the tumor within it. So, when we do skull base surgery, we are not really going to think as sinus surgeons where we are going to talk about mucosal preservation. This is a malignant tumor, and not to mention it is a neuroendocrine tumor. So, this was a cortisol secreting tumor. So, this lady's blood pressure was through the roof when we were operating on her, because the tumor secretes a lot of cortisol. So, luckily for us, what happened was this was a very surgeon friendly tumor. So, we could suck it out very easily. This was not like a hard fibrous tumor. Hard fibrous tumors tend to have more attachments to the carotid, and that helped us in this case to get a complete gross total resection, or you can say in head and neck terms it would be R0 resection is what we call this. So, here you have to drill down all of this bone and make it plain and flat as much as possible, because for 2 reasons. One is this tumor tends to infiltrate into the bone. So, when you leave behind this bone, then your chance of having a recurrence or growth is very high. The second reason is when you want to do, if you want to do any kind of reconstruction like a flap or something, you need to have a flat surface to position your flap. What you are looking at is actually the sella turcica there, that is the pituitary, and now below that, above that is the optic chiasm there. We are now clearing up the carotid, the clival area. I am not sure why the video is, so that is the carotid. I do not know if you can observe very clearly, that is the carotid. So, that is a cavernous segment of the carotid, and we are trying to create a plane of dissection by going behind. So, this is the sella, that is the cavernous segment of the carotid, and I am actually pushing a piece of gauze into this space. वीडियो क्लैरिटी कुछ कर सकते क्या? इधर तो अच्छा आ रहा है. It's fine. Yeah. Okay. Yeah. So, what I am doing here is something called as a soft dissection, where I am pushing a piece of gauze into the retrocarotid space, and we are now drilling into the basipterygoid area so as to expose the other side carotid. So, once we drill out all of this pterygoid bone, what you can see here is actually the maxillary sinus, and we were drilling in this area to expose the carotid on the other side. So, once we expose that, again like you saw in the scan before, we have to again go behind the carotid in that space as well. So, now you can see what do you have behind this carotid. This is a hollow area where actually the petrous temporal bone is going to be visible. Now, we are actually reached the petrous apex once you go behind the carotid. And when you are doing this maneuver, be very careful, because in this area here you will see a horizontal structure which is nothing but the Dorellos canal or the abducent nerve which is going to be present. As you drill laterally in the clivus, you will actually come across the Dorellos canal close to the petrous apex. So, you should not cut through any of these structures. What you want to do is anyway here we were lucky that the tumor was very suckable. So we could actually go, and what you're seeing now is with a 70-degree scope. I'm using a 70-degree scope and looking far lateral so that I can get a complete tumor clearance. So what I am doing here is now pushing a piece of Merocell into this space so as to mop it, or like my boss used to say, pocha lagao. Satish Jain used to say that all the time. So here, instead of putting in brute force, just use a piece of Merocell, and this is what soft dissection is all about. So you put pressure on the Merocell and not directly with a suction or anything, so that you don't damage any of these structures, right? And the second thing is, when you put a piece of Merocell, there is something called as volume displacement that happens. So it is a closed space. Either a tumor can be there or Merocell can be there. You can't have both together, right? So when you push in Merocell, tumor comes out. So in that way, you can actually preserve the integrity of the structure as well. So this is called as soft dissection and volume displacement technique. This is not mentioned anywhere. This is just my terminology, what I'm talking to you about. And now you can see there is some Surgicel sitting behind the carotid, and there are two landmarks which we have used, in front of the carotid. This is on the opposite side, this is on the right side, where we have again gone close to the petrous apex, behind the carotid again, and there are two surgical landmarks which help me identify the carotid. So what happened in this case, interesting fact which I will just mention shortly. So this is behind the carotid, that is the cavernous carotid, and here we have the petrous carotid. So there are two landmarks. If you can see, this is the Vedian nerve which was preserved. So the Vedian nerve is a very good landmark for the petrous carotid, and if you observe above, there was one more structure which is actually the infraorbital nerve or V2 segment of the trigeminal, which is a very important landmark for the cavernous carotid. So with these two landmarks, now in between these two areas, when you actually there is pneumatization, that is called as the lateral recess of the sphenoid. So the tumor was actually occupying even that space, and tumor was cleared from that area as well. Now here inferiorly, this is actually the posterior pharyngeal wall mucosa, or we are just below the level of the adenoid. We are at the level of the soft palate, where we are removing all of this mucosa down, and this is the clival, this is the clivus area which is completely eroded by tumor, and that is the sella. Just for orientation sake, that is the carotid here and the carotid here. So after packing this complete space out, and that is the eustachian tube on both sides, what you can see, and look at the proximity of the eustachian tube to the carotid. It's hardly about a centimeter away from the eustachian tube. Okay, so this is how we were able to completely clear out this tumor, and this is the Vedian. You can see the infraorbital nerve there, which is pointing towards the cavernous carotid. So once this was done, and you can see that now I have packed this whole space with Surgicel, and that is the petrous apex on this side. You can see the posterior cranial fossa is actually, the brain is pulsating there. So be very careful not to create any CSF leak here. Why? Because even if there is microscopic tumor, when you open the dura, you are allowing this to percolate intracranially. So there is going to be tumor spillage intracranially. So be very careful. And you have observed one thing, sir was saying that it is quite bloody, but at the end of surgery you can see once the tumor is removed completely, the bleeding absolutely stops. In fact, I didn't even pack the nose in this patient, I just put a Surgicel layer, and we were able to get away without any bleeding as well. And this is the post-operative scan where you can see complete tumor excision is done. You don't have to take my word for it, you can see the PET scan here, and you can see that there is absolutely no yellow hot spots there. What you are seeing is on the margin just inflammatory mucosa, and we even confirmed this with a biopsy, and the biopsy has come back negative after the surgery. So this way we can actually completely clear out tumor here as well. This is the second case that I want to show you is, sorry. So the second case that I want to show you is a little weird type of case. So this is a 15-year-old boy presented with a facial deformity. He has undergone open surgery before. This was an angiofibroma, and what you are seeing, the picture now, this was close to about 420 or 480 grams of tumor. Practically speaking, half of his face was filled with this tumor, and you can see that this is the infraorbital foramen. Through the foramen rotundum, it had gone almost close to the Meckel's cave. It's come almost up to here. Skull base orbit has been completely compressed out. So normally what the strategy was before was that if endoscopic surgery fails, that is when we switch to open surgery. Here we have reversed that concept, and open surgery had failed and we did endoscopic surgery and we got a complete clearance. So here what you have to do in such a massive tumor, you have to split the tumor into multiple segments to make life easier for you in different phases. Here we split the tumor into 7 segments. The first segment you want to actually attack is the nasal component of the tumor. That is for 2 reasons. One, you need space for instrumentation. Second, you want space for the blood to actually flow backwards into the nasopharynx so that you can put a suction there and suck out all the blood. And mind you, this is actually a very vascular tumor. This is a 3rd time revision. That means I am the 3rd surgeon operating, twice operated before. First time endoscopically, second time open approach. Okay. The next component that you want to attack is actually the maxillary sinus component. Why? Because the IMAX or the internal maxillary artery is actually present behind this component. So what you need to do here is, once you've cleared the nasal component, you can actually push this maxillary sinus component into the nasal cavity and sort of go behind the tumor and clip the IMAX here. And what I found in all of these tumors is that the coblator works like a charm, because you combine all 3 things into one equipment, that is irrigation, suction and bipolar. All these 3 get combined into one just instrument. Not to mention that you can, it is quite a malleable equipment, so you can actually bend it in any which way you like. The problem we have when we use bipolar is that the more posterior you go, the prongs actually close down, making it very difficult for you to utilize that level of equipment. And here time is of essence. If you've got an IMAX bleed, you don't have time to actually manipulate the bipolar, but with a coblator you can just straight away go in, it's got a suction attached to it, and you'll be able to manage the bleed very comfortably. So here you can see the IMAX has got 2 branches, of which one branch we have actually cut, and we are able to actually use a bipolar, and very swiftly within a matter of 5-10 seconds you can actually coagulate this whole thing. Of course we did clip it. What you are seeing here is the temporalis muscle. The vertical fibers are always temporalis. It is the horizontal fibers which are the pterygoid muscles which you see there. So once you reach that area, again the same philosophy, soft dissection and volume displacement, push a piece of gauze into that space and the tumor will actually pop out rather than you trying to fish it out with a sharp equipment. And you can see the whole tumor was out, and we were, of course it's a lobulated tumor, it has been devascularized because the IMAX is now cut, it's lying free in the nasal cavity. You don't need to waste your coblator on this anymore, use a scissor and cut it out. And you can see delivering it through the nose was quite a challenge. We had a tough time pulling it, even though we cut it into 3 different parts. Now that is the temporalis muscle bed, completely clear of tumor. And now this is the cavernous sinus area where I am just putting this Surgicel. Why I am putting this Surgicel is because I am going to use it as a marker. So that will tell me where the cavernous sinus is at all times, so that I don't injure the carotid when I am trying to probe or I am trying to use any kind of equipment. This is the pterygoid plate that you are seeing, and I am in the peritubal space. That is the area of the eustachian tube and fossa of Rosenmuller, where we are actually going, and as we go over you will actually come onto the clival segment there. So there was a lot of tumor sitting even in this area. You have to go inside and push it out. So here you can see that Surgicel is actually the cavernous sinus. Now we are tackling the sphenoidal segment. There is one part of the tumor here which is actually going through the Meckel's cave. So the Meckel's cave is the lowermost point of the cavernous sinus. So if you can imagine an inverted pyramid, then the apex of that pyramid is where the Meckel's cave or the foramen rotundum is. So as long as you are below that level, you are in the safe zone. If you go above that level, you know that you are going to enter into the cavernous sinus. Okay. So use that as a landmark for yourself. And this intracranial part of the tumor, always leave it for the end. Why? Because if you try to address it initially, one, you don't have space to maneuver your instruments, and second, if you have an intracranial bleed at the time of, in the beginning of the surgery, you will have to abandon the case and do a craniotomy. So that is the reason why address it towards the end. So this is the optic nerve on the left side, and this is the area of the cavernous carotid artery. There is some bone which is actually quite cribriformish, where the tumor would have gone in. So we have to drill that area out to make sure we don't have recurrence. This is the last part of the tumor which is sitting in the foramen rotundum, and what you are seeing when I peel this tumor off is the medial temporal lobe of the brain, which you can see here. Okay. So we have to delicately peel this tumor off of the medial temporal lobe of the brain without causing any complication here. Mind you, this is a very important part for speech and language development, that too in a 15-year-old boy. So use an angled instrument like this and peel the tumor off. Needless to say that the basipterygoid has to be drilled out completely to prevent recurrence again. Basipterygoid, basisphenoid bone has to be drilled out completely. Make sure that your drill does not slip. If you slip and injure the medial temporal lobe, you are going to be in a soup. So also, because the dura is going to be stretched because of the tumor here, it would make sense to use an artificial redura or something of that sort to prevent any kind of CSF leak or herniation in the later stage. So this is what the patient's post-operative picture looks like, and this is what the endoscopy also looks like in these patients. This is, I think, about 3 months after surgery, and you can tell that it's a wonderful result. He's not had any recurrence. It's been about 2 years since we operated. Not had any recurrence so far. This is one of the last few cases I want to talk to you about. This is a patient who's had a glomangiopericytoma. Now this is an extremely rare tumor. So I was the 4th surgeon operating on this tumor, again 3 times revision. So the problem that you have here is this huge parapharyngeal, upper parapharyngeal space component which is going down. If you observe, it is going almost up to the level of the epiglottis. So we are talking about somewhere at this level here, just below the level of mandible. Now this is, as far as my knowledge goes, this is one of the very few cases. Probably there are 2 people in the world who have done this before, and me being one of them. The first person to do this was from China. I can't really pronounce his name, but we have done an endoscopic approach to the parapharyngeal space, where we have gone, usually what we do is we put a cervical or a transoral incision and remove this component, but here with an angled instrument we were able to go transnasal into the parapharyngeal space. So first, this is what the tumor looks like, and I have to, full disclaimer, this is the only tumor that I have actually staged in my life, because this was just a 22-year-old very lanky, tall guy, thin guy, and just in the first stage when I removed the nasal and maxillary component itself, he had lost so much blood that we had to go back and maybe after a week or 10 days we came back and did the clival segment and the parapharyngeal space segment. So it is not about our ego, it is about what the patient really needs and how we can clear it out completely. Okay. So once we remove the tumor, this is the maxillary segment. You can see the lateral wall of and the posterior wall of maxilla. We have reflected the tumor into the nasal cavity, and that is the tumor attached to the the medial temporal lobe as well as the infratemporal fossa fat. So this is an oncological resection. So when the tumor is attached to the fat, we have to go ahead and remove it completely. That is the temporalis muscle, you can see, which is free of tumor. So that completes oncological resection over there. Middle cranial fossa dura, tumor is completely peeled off of it. This is the peritubal parapharyngeal mucosal space. We are going to go down into this space by drilling the pterygoid. Normally this space is actually closed. You will not find it open in the human body, but because the tumor has penetrated into this space, it's opened up. So that makes our life a little bit easier. So when you drill the pterygoid plate down and you go into this space, you will be able to see that with a 70 scope we can look down, and 60 rad debrider, you take the tumor out completely all the way down to the point where you can't see any tumor anymore. So this is the superior constrictor muscle medially which you are seeing here. And again, like I said, don't take my word for it. This is about 6 weeks after surgery, and you can see that the PET scan is not showing you any uptake in this area here, and you can see that the tumor has been completely excised. So this is a gross total resection of the tumor. I'm not going to show you a video of this. This is a very rare case which we had done. A 43-year-old presenting with an angiofibroma. Again, this was the 7th time revision that we had done. So I was the 7th surgeon operating. What I want to tell you is that it is not always about the surgeon. So here, 4 times when we biopsied and sent the tumor for biopsy, it has always come back as angiofibroma. But nobody really bothered to do an immunohistochemistry on this. So this patient had an androgenic receptor which is positive. So instead of going on operating on him, we can actually use the help of flutamide to actually help control this problem. So it is not always about surgery. When you have a hammer in your hand, everything looks like a nail. So use a little bit of brains, and actually if you add flutamide to this, of course we did have to operate because the tumor was very big for flutamide to work on its own. So after we operated, you can see that the tumor has been completely removed, but to keep him in remission, we have to use something like flutamide. So use the help of your colleagues. Medical oncology colleagues. So how do we reduce recurrences and improve outcomes? In the beginning of your career, stick to smaller tumors. That will help you boost your confidence. Okay, it's a learning curve. spent some time and money. I was lucky enough to train with one of the legends, Dr. Satish Jain, for a year, and he actually taught me a lot of what I know. Surgical as well as non-surgical, not just about how to do surgery, but also how to read scans. If you don't know how to read scans, you're not going to be able to tackle the tumor completely. The first case that I showed you where we had to go behind the carotid, halfway through my navigation equipment failed. So I can't rely on navigation all the time to actually reach where I want to reach. So because it failed, I had to rely on my own knowledge. That's why I use the VDN and the infraorbital nerve to trace the carotid out. So unless you know where to go, you will not be able to complete these surgeries. Use a team-based approach. Now there is evidence to prove that it helps reduce operative times. Also, it reduces the complications associated and improves outcomes in the long term. But remember one thing, a team is only as good as its individual members. So if you've got someone who's just fresh off the boat and expect him to do a lot more, it's not going to happen. You need to invest in their training also if you want to build the team. And aim for complete resection. If you're not able to do it or not confident, please seek somebody's help who can. Study the scans very well. In fact, have multidisciplinary team discussions on this, and also note down what are the future therapy options if you're not able to remove the tumor completely. Very, very important, have the right equipment. You need to have all these things like coblator, drills and everything in your hand. Your skull base reconstruction has to be airtight, because remember, that is the starting point for a plethora of problems. It's like opening a Pandora's box. I have seen cases right from just a leak all the way up to encephalitis, where the frank abscess has happened and you had to open and drain it out. Counsel the patient well multiple times as a team, including your nurse also has to counsel them and document them more for your medical legal purpose. Document even phone call discussions that you have had with the patient in skull-based surgeries, and stick with your patient till the end. Don't abandon them. Just because your surgery failed, convince the patient or either get somebody else to operate, make sure the tumor is completely cleared out, or use the help of your radiation oncology colleagues or medical oncology colleagues, and don't just abandon them saying, I can't do anything or it's not my problem anymore because you got your money done. So the last thing I want to leave you with this picture is, even a tiger takes 2.5 years to learn a basic survival skill, that is hunting. We are just humans after all, so invest a lot more time in training, especially with people like Dr. Kirtane or Dr. Satish Jain or Dr. Ashim Desai sir, who can actually teach you how to hold the reins before you can ride the horse. Thank you so much, and I hope you learned something from today's lecture.
Thank you so much, Dr. Gaurav Medikari, for a wonderful session. I request Kirtane sir to please felicitate with the token of gratitude to Dr. Gaurav.
I think that tiger signifies something here. The attitude, the aggressiveness to go after the tumor to the every last bit that is there and remove it. Yeah. Congratulations. Thank you very much for a wonderful presentation. And
I request our next speaker, Dr. Ashim Desai sir.
I just want to say one thing. Yes, yes. I've been seeing Kirtane sir since I was, this small. Probably I think I was about 4 years old when I first remember meeting him in the children's hospital where my dad used to work. And I have to say that, my life has been, all about inspirations. And I mean, I'm always looking for inspiration, even from movies. And I have to say, you're the biggest hero that I've had in my life. Thank you so much for inspiring all of us to do what we do best. Thank you, sir.
So our next speaker is Dr. Ashim Desai sir. He has enriched experience, obtained specialized training in the field of middle ear and mastoid surgery at the House Ear Institute in the USA. He has done more than 6,000 stapes surgery and more than 20,000 other otologic procedures. Doctor has invited as a guest faculty over 200 regional, national, international workshop, Also, doctor has a special interest in allergic diagnostic and therapeutic and immunology. Also in sleep surgery, management of sleep related breathing disorder. He has been one of the early adopter for laser coablation assisted and microvider assisted surgery. So over to you, doctor. Thank you.
Thank you very much. It's an honor and pleasure to be here today. Thank you, Alkem, for making this happen, and very special thanks to my guru, Professor Kirtane, and we go back a long way. He's been my teacher in my postgrad days, and I'm truly grateful to him for all the teachings and in life as well as ENT that he has given me. Thank you, sir. So the latest step in my journey is my interest in the management of the paralyzed face. It, of course, you know, it is a natural corollary to my interest in otology. And what happens is that facial paralysis is a deeply traumatizing condition causing tremendous distress and emotional stress. And since the treatment of acute facial palsy has been with or without facial trauma is already well described, today my focus is going to dwell upon management of the permanently paralyzed face. So we are talking about facial reanimation here. So this is something, what are the aims of facial reanimation? One is to establish static and dynamic symmetry. Second, and most important, of course, is eye protection. Third is emotional control. Fourth is improved speech, aesthetics, psychological benefit. But please remember that the treatment has to be individualized to each patient. So basically, one size does not fit all. So the question that begs to be answered is when to intervene and what should we do? Please remember that when you are planning management, the recovery rate predicts the long-term function. So just as an example, there are a lot of people who wait for 6 months and 8 months and 10 months after incomplete recovery following Ramsay Hunts or Bells or whatever. But the statistics say that if there is a 5 to 6 grade house Brackman at the end of 7 months, there's less than 10% chance of good recovery. That means bringing you back to house Brackman 2 and 3. And if there is complete paralysis like house Brackman 5 and 6, at 9 months, the chance of recovery without intervention is only 1%. So waiting forever is certainly not an answer. So even if, just as a discussion, even if you have a slow onset of recovery, no great improvement in 6 months, unequal recovery across the face, other signs and symptoms, most likely this is not Bell's. It needs to be investigated further. Now, when you are planning the restoration, from 0 to 18 months, please remember that you have viable musculature. From 18 to 24 months, you may continue to have viable musculature, but it's a question. But beyond 24 months, trying to do anything with the existing facial musculature that is post-paralytic palsy is like flogging a dying horse or a dead horse. So what is the management algorithm of facial palsy? When you are, there are two things, surgical procedures, non-surgical procedures. For surgical procedures, you can have static or dynamic management. When you're considering dynamic management, the early dynamic management would be the nerve repair or a nerve graft. When the paralysis is between 18 and 24 months, you can use a cross-face nerve graft as well as a nerve transfer. And when it's beyond 24 months, you can use either local muscle or free muscles. Now, as far as static ancillary procedures are concerned, you can use tarsorrhaphy, lid loading, brow lift, static slings. You can even use barbed wire to just give an eyebrow lift, so on and so forth. But those are ancillary procedures not to be used as a primary situation unless the patient's condition warrants that something should be done. Non-surgical procedures, of course, is chemodenervation for extremely hyperactive, that is syn kinases, and physical therapy like soft tissue mobilization, arthat massage, electrostimulation, biofeedback, neuromuscular retraining, so on and so forth. But at the end of the day, the non-surgical procedures can only help a little bit, but they don't create a good advantage for you. So when you are planning the restoration, please note that I am very new at this game And now, at this point, muscle transposition for policies over 24 months represents a very good option for us. One, that is the lengthening temporalis myoplasty. That's the Labe and the modified Labe. So what happens is that in this you advance the pedicle temporalis muscle and insert the tendon into the nasolabial fold with a fascia lata extension. When you insert it into the nasolabial fold, you have a very predictable facial muscle movement by transfer of innervated muscle, because you're not destroying the innervation of the muscle. It's a short surgical time and it is not very bulky. However, the biggest disadvantage is that there is no spontaneity or emotional movement, and it's very good for tone and symmetry where free muscle grafts are not possible, such as in an irradiated patient. So this is one thing that you can consider. It's a very easy procedure, and one of the techniques I've learned with my guru on facial reanimation is an incision in the nasolabial fold and elevation into the excision of the coronoid process and pulling the temporalis down from there without any mobilization with temporal incisions, and then extending that temporal tendon, the tendon of the temporal, with fascia lata sling inserted into the angle of the mouth. And this gives very, very good results. You can see that this is where the incision comes from. Where's the pointer? This is the incision. You can use either a drill, or better still, you can use the piezo to pull down the coronoid, to remove the coronoid process. Hitch it with slings of the fascia lata, and this is a very simple, very effective procedure in order to restore some degree of movement to the paralyzed face. Better still is the nerve transposition. Of course, everybody knows about the hypoglossal fascial anastomosis, but it has very good tone. It's a very powerful nerve, so it has a lot of tone, but very strong but very poor movements. So today we have moved more to the mesenteric nerve, where although the tone at rest is medium, if you direct only to the ignore the frontal branches and ignore only and focus only on the zygomaticobuccal branches, there will be good, powerful smiling movements with a better than 90% success. And of course, the contralateral use of the sural nerve. So that has very little power because there are very few axons in this, and very negligible resting tone, but the highest quality of movement, because the high quality of movement is defined by spontaneity and emotional. So what is the best way possible? Why not all three? So this is something that is the big proponent of this is Professor Federico Bilioli. My co-conspirator in this journey is, of course, the inimitable Ashish Bhumkar out here. So together we have gone to Professor Bilioli, and you will be seeing, all of you who are coming to the ISOCon will be seeing him in action at the end of this year in November at Agra. So you can imagine the beauty of the Taj Mahal and the beauty of the restored face along with him. And he describes the triple innervation. Now, what is the advantage? That means what? That you are using a cross-face nerve graft to give spontaneity and volitional movements. Volitional movements are given by the masseter because it's very easy to train the masseter to give you the smile. And you are having a good resting tone by using the great auricular nerve to transfer electrical impulses from either the hypoglossal end to side of the masseteric nerve. So this triple innervation is going to be the workhorse of the future as far as this is concerned. So what happens is the advantage of the masseteric nerve is rapid restoration of function because of the dense motor fibers, about 15 to 1800 neurons are available. So it provides very good, reasonably good muscle tone and powerful innervation. And there is a very great ease of cerebral adaptation. There's minimal donor morbidity, but the biggest disadvantage is synkinesis, and this is solved by directed selective re-innervation. So re-innervation that is being described by Professor Bilioli and that I've started following is that it should not be to the entire trunk of the facial nerve, but selectively to the zygomaticobuccal, so that we have more power towards the smile, and the eye is taken care of by lipofilling. Today, lipofilling is more in trend rather than using the gold because of the deformity caused by the bulge of the gold. Simple lipofilling using a liposuction cannula, about 2 ml of autologous fat is used, and it works extremely well. So this is a short video of the mesenteric nerve to the facial anastomosis, the way we do it. And it's a classical modified Blair incision. I should try and be brief because what is happening is that we have run out of time, and I'm sure most of you are hungry. I believe there are more speakers after me. So this modified Blair incision is extended temporally. Sorry. Oops. Dinesh, I can't move the video cursor because this is a 15-minute video. I need to move fast. Video cursor चल नहीं रहा है. Full screen दे दो ना. So this elevation is done. And now we are trying to dissect out the nerve. Now what are the landmarks for the nerve that you want for the zygomatic branches? Is that it is about 1 centimeter below the line joining the lateral canthus to the tragus, and go below, and anteriorly the anterior part of the parotid start dissecting out there using the Colorado tip. And here you can see, you can find the parotid duct, and just below and around the parotid duct you will find the branches of the nerve. Now, once you found the branch of the nerve, you trace back to the main trunk and use only that branch of the main trunk that is supplying the zygomaticofacial. Once it's identified and divided, then you go looking for the mesenteric nerve. Mesenteric nerve 4.5 millimeters anterior to the tragus and about 1 centimeter below the zygomatic arch, and we start dissecting out there. Remember that the direction of the mesenteric nerve is oblique, and it is below this aponeurosis. So the aponeurosis is divided. Remember, this is not the zygomatic, this is not the mesenteric nerve. The angulation of this is just a tendinous fiber. The mesenteric nerve goes from posterior superior to anterior inferior in an oblique 45-degree angle. This is the mesenteric nerve now. Once it's identified, you try and extend as much as you can before you divide it, the maximum length possible. Remember that we use nerve stimulator. I'm sorry because we are moving a little bit fast here. We're using a nerve stimulator to make sure that the mesenteric nerve is the right one. I am trying to yeah. Swap करना. I know. Display. है ना display? Yeah. Duplicate करो. पहले लगाओ फिर दिखेगा ना. Yeah, take your time. No rush. Yep. Best procedure. Okay, no problem.
So I will do that. Nothing need to do. Just we need to remove this.
Play.
Slideshow now.
नीचे जाकर क्या करना? Slideshow. नीचे.
नहीं सर उसके पहले मुझे प्रेजेंटर व्यू निकालना है. If I can remove the presenter view, nothing will come here. Arvind, change मत कर.
How have you reversed this look?
Sir, I will do that. अरे यार किधर गया?
Are you still in your PowerPoint or your? Why don't you go to the folder? Yeah, I'll do that. वो मैं क्विक टाइम पे ही बजा देता हूँ.
हाँ ठीक.
Okay. Just now, what we'll do is we will just.
Arvind switch. सर डिस्प्ले में सिर्फ मॉनिटर है बस. सर ऐसे ही करके प्ले कर देंगे.
Okay. Is this good? All right. How's the picture now? Okay, thank you. Okay, so we are going back to dissecting the nerve. And that's the mesenteric nerve now. We are dividing the nerve as long a segment as we can achieve. Now we're going back to divide the facial nerve. This is the zygomatic buccal branch. This is the upper trunk. We are not doing anything with the lower trunk. Maximum length possible again. And now we try and anastomose both of them together with 8-0. Going to a higher magnification now. So that's the facial nerve. And that's the mesenteric. 3 sutures are taken. Epineural sutures. 8-0, sorry. Sorry? 8-0 with a PDF? No, Proline. Yeah. Permanent sutures. So, I mean, they're just sutures at the end of the day. So, a couple of sutures there. Typically, we use 3 sutures. And once the anastomosis is done, now remember, this was an 18 or 19-month-old paralysis, so it's just on the borderline. One more suture, just for good measure. And once this anastomosis is complete, closure is achieved. Now, yeah. So now let us go back to planning the restoration when you want to do a free muscle transfer. More than 18 to 24 months, you require to use a free transfer. So we will use either a gracilis latissimus dorsi or a serratus anterior has been described. Typically, For us, we are just starting to use the gracilis now. So it's a two-stage procedure. In the first stage, two contralateral facial nerve grafts are placed, sural nerve connected to the buccal branch and end to side on the branch to the frontalis and placed on the paralyzed side. 9 to 12 months later, you see a positive Tinel sign. And at a second stage, a segment of the gracilis muscle is harvested along with the obturator nerve and vessel, joined to the facial artery and vein, and make sure that the ischemia time is limited to 1 hour. The mesenteric nerve is then coapted with end-to-side anastomosis with a cross-face nerve graft. And typically, a bipedal gracilis is used for independent movement. Around 25 grams of muscle is good for this. Along with this, lid loading with lipofilling is used. Eyebrow lift can be used with a titanium screw and barb suture. So what happens in the temporal bone, you just take a titanium screw, tie a barb suture around it, the loop goes around it, bring it endoscopically, tunnel it down over to the eyebrow, lift it up, and that's the end of it, one of the easiest procedures on the planet. For the lower lip, this I have not yet done, but this has been described. Anterior belly digastric transfer for paralysis more than 18 months, platysma nerve transfer. But in the first photograph, if you remember the girl I have done, I have opposite side depressor labia inferioris excision has been done in order to match the smile. So, in addition, you can use a great auricular nerve. You can get up to 7 centimeters of length, and that can be used as a connector for the, if you want to do a triple nerve innervation from the ansa hypoglosside to one of the branches that you are planning to innervate. Electrotherapy is done. I'm working with a couple of good electrophysiologists here for 6 weeks after muscle transplantation. And these are what has been recommended by the electrophysiologist. So these are my first few steps. And I ask you also to look at this. I ask you to challenge the status quo. And I ask you to join with me on the path less traveled. Let us help these very, very depressed, very unhappy patients. Thank you very much for your time. Thank you once again, sir.
Thank you. Thank you, Ashim. Brilliant as usual. And I think this is a long neglected area where the plastic surgeons were doing something, but if you can reanimate the face and give hope to these patients, it's a great thing.
Thank you.
So congratulations on your efforts, and we hope to hear more about this once your baby steps are over. Okay. Any questions?
How much time does it take to re-innervate?
Surgical?
No, to re-innervate afterwards.
To re-innervate. Typically, it takes between 9 and 12 months for the axons to start working. You start seeing movements, electrophysiological, you start seeing recovery potentials around 7 months. And then over a period of time, it reanimates after that, 9 to 12
And
months.
how much would be the role of physiotherapy so that muscles don't undergo wasting during this time period?
During that time, that is what we call the babysitter graft. So what we tend to do is connect the muscles, like a 5-7 kind of thing that you saw, to the facial nerve, while we wait for the cross face to grow. So that babysitter graft is used in order to maintain the tone.
No more questions? Thank you. Thank you
you,
very much, Ashim.
Thank you so much, Dr. Ashim Desai, sir. Thank you, and a deep gratitude for all support and coordination you have done for Dr. Vincent. Thank you so much.
So Ashim was mainly responsible in managing to get Dr. He was busy with some jazz concert which he organized, but Ashim managed to pull him out for that. And you heard how close they are from Robert Vincent himself. Yeah.
So please have a token of gratitude.
Yeah, Divya, you're on.
Our next speaker is Dr. Divya Prabhat. Dr. Divya Prabhat basically from Mumbai, and he got trained in ear surgery for defense in Germany and done cochlear implants training in Royal Australian Hospital, Melbourne. So over to you, sir.
नहीं चाहिए, सिंगल लेता हूँ, सिंगल ये सर स्लाइड शो में जाने का, ये नहीं, ये चाहिए बस, खत्म हो गया।
Respected Dr. Kirtane sir, our teacher from 3rd MBBS to today, my respected seniors, colleagues and friends from sitting here and all over the country, I mean whoever are with us. So we'll be basically taking you through the pediatric airway. I'll be cutting short to the lower airways with the restriction of time, and why this becomes different or a little, it's important as far as the pediatric part is concerned as compared to adults. Because children are basically having larger heads as compared to the whole body. They are primarily obligatory nasal breathers. The tongue is very large. It occupies a very large area in the oral cavity. This is for the purpose of sucking and swallowing. The subglottis is, very narrow. The epiglottis is floppy. The anterior larynx, it is at C2, C3 level, at a much higher level. The trachea is smaller. Then you have Bernoulli's phenomena coming into, and the lung capacity is less. So classically, the difference in pediatric as compared to the adult is quite massive, and therefore, you'll understand with the funnel-like picture of the larynx that the infant subglottic area, which is the crucial area where all the problems occur with respiratory problems. And this you can understand with the simple figure that even a 1 millimeter edema of the respiratory tract causes reduction of the area by 75%. So 75% cross-sectional area reduces even with a 1 millimeter reduction. And therefore you find saturations falling so fast that within a minute we found them going from 100 to 0 and 0 to 100. So how do we evaluate these children? With a history of how they present to us with time. If they are post-delivery, we suspect a web or a congenital stenosis. If it occurs with feeding, it is TOF. Up to 3 months, then you find lymphangiomas, hemangiomas inside. If it's following any intubation, it may be either due to trauma or granulomas. With infections, it could be laryngotracheobronchitis, and if it is episodic, it is asthma. So children basically are obligatory nasal breathers. The first picture that you see is this child where the nose was absent. And when we got a call, we could not resuscitate the child. So even 2-3 minutes, the child cannot prolong if the nose is absent. So they are obligatory nasal breathers, and it becomes very important that they have to be dealt immediately, or we diagnose chaos on ultrasound, in the 3rd trimester. These radiologists tell us that it is chaos and you have to be ready for the purpose. And unilateral blockage is comfortable, you can do it at any day, Now how do we assess these children? The best thing is, do not first go and examine this child, see them from a distance. Because when they see a stranger, they will start crying and you lose all your findings. So stand away, watch them from a distance. Whether you hear the breath sounds or not, and whether these sounds, whether it fits as a snoring or a stridor or a stutter, and if the respiratory efforts are causing retraction. Positioning becomes very important for the children. Now, as you know, the oral cavity has a vertical and a axis, and these axes have to be brought into a single line. So what you can do, the simplest method is that keeping a small towel or a piece of a small pillow below the head would automatically make the vertical axis more horizontal or the horizontal axis more vertical, getting all three of them in one plane. And as far as the infants are concerned, it is very, very important that the head should not fall on the neck. So if you remove flexion, nearly 50% of the airway can be opened up. So the towel or the pillow should not be kept below the head, it should be kept below the shoulder, and therefore the head can be moved in that position. So head positioning is first prime thing that one should follow after this. Now the commonest thing will directly come on to the lower airways, because upper, I mean nose and throat, you see quite a lot. So we'll just start with laryngomalacia. This is a very overdiagnosed condition. Unfortunately, all the patients who come from the pediatricians or from the neonatologists come with diagnosis of laryngomalacia. The reason is they call it laryngomalacia because they have not seen the larynx. They have not visualized it. They have just seen that, there is stridor, respiratory problem, and it is labeled as laryngomalacia. Now we know that once we start seeing every child, we know that there are so many conditions other than laryngomalacia that we encounter which are treated. And so unfortunately, they go on for a long time. So laryngomalacia is where when we get the crowning noise and the diagnosis is made that a normal size tube goes in. A normal size tube goes in, that this is laryngomalacia. Unfortunately, or fortunately, you can say all children are not affected, those who have laryngomalacia. They can be controlled medically. Practically, no patient of laryngomalacia requires surgery. It may be just 0.1%. If we just take care of a good nutrition, they are treated for upper respiratory tract infection in time, and adequate positioning, that is prone, semi-supine, semi-lateral position given, laryngomalacia does not require surgery. This is laryngomalacia where, of course, it was quite severe and the patient not responding, where supraglottoplasty is done, but treatment surgically is quite, you can say, negligible. I mean, practically you require to see few hundreds of patients, and then you find one patient, who may not respond would require surgical procedures. Sorry. As I said, a lot of cysts are seen. Like for example, this was our last paper, and now I think Dr. Kurup is coming out with 29 cases of, we have just done 29 cases of valvular cyst who had come with stridor, and these children were all diagnosed with a valvular cyst. So with laser excision is done and the epiglottis is sutured in front, whether stitch is removed at a later date. So valvular cyst is again a very common condition which is seen, and again all of them come to us as laryngomalacias. Apart from this, there are a lot of conditions which are as misdiagnosed as laryngomalacia. You can see from this either it may be because of edema, a papilloma, or it could be even hemangiomas. Hemangiomas you suspect when you see the oral cavity, you see classically the parotid area, the submandibular area, there may be hemangiomas on the face of the child, very high suspicion that they'll have a hemangioma inside. Obviously, they don't require or you don't do any surgery. We just keep them on propranolol, 6 months of propranolol, and these children do very well. Or it may be a rhabdomyosarcoma, which would require again different form of treatments. So all of them come to us with stridor, so-called laryngomalacia, but turn out to be various different conditions that one may see. Now what we have to remember that in children, very often we see that when they are intubated, they come out with some amount of trauma, edema around the glottis, supraglottis, or even in the subglottis. Now since the larynx is such a small structure, and managing trauma to the larynx is a very difficult proposition. I mean, surgically to treat it, it is so difficult. The child undergoes multiple surgeries and the whole recovery becomes prolonged. Most important is this is always a avoidable situation. We can prevent it. The commonest reason of even subglottic stenosis is iatrogenic. Iatrogenic cause where we find children who have been intubated once, they come with subglottic stenosis, and so very important is the tube which is used for children should be one size smaller than what their airway is, because the same size tube will lead to definitely trauma, and that is dangerous for the child. So never go on to that this is a male and this is a female and this requires a higher tube or a lower tube. You may have Tom Cruise also over there. So thing is, always use a smaller size tube because they develop subglottic stenosis, and with subglottic stenosis, the whole treatment protocol becomes quite lengthy. I mean, they take 3 to 6 months to recover, and of course we do this cricoid split and we do the cartilage grafts. Now, what is an emergency? Emergency is only when the obstruction is at the glottic level. It's at the glottic level where you don't have time and you really require to be fast and you have to remove conditions. This is like this was a cement piece inside, or there could be an inlet obstruction where you find a toy or a structure which is there at the inlet. So unless the child is blue, or if they have lost, the pulse is not seen, they are not maintaining saturation, it is only then that you have to consider doing the various maneuvers. Otherwise, these conditions do not actually, if you do a maneuver and you lose a child in the process, things may worsen for the doctor itself. Now, this is at a nursing home just close to the venue where we are sitting. One of our ENT colleagues had called us. The child came in stridor, and in stridor, when we put the laryngoscope, we found a mass over there. And he was being treated again for respiratory problems with the physician. So through the tracheostomy, we put in the scope to check whether the bronchus is normal or not. All this done at a nursing home level itself. And the subglottis itself was closed, indicating that this was a papilloma. Since we had a CO2 over there, see this is the subglottis, and you can see the subglottis closed with the papilloma. So this is the point, at the stage at which the patient comes to us. So with CO2, we cleared the papilloma at the same sitting, and after this, on the 4th day, the tracheostomy was removed. So whenever there is stridor, along with dysphagia, it is important that we also do a barium, and we may find different conditions like persistent aortic arch, etc. Now, this is just to give you an idea how important the airway was, that this boy just done his tracheostomy 26 years ago on a ventilator. Now, he's on a ventilator, and for the last 26 years, he's on a ventilator. So, and now, he himself has started manufacturing ventilators. In Goregaon or the Nesco, he keeps a stall and he sells ventilators. So every breath is on a ventilator, and how important is to have the airway with these children, A very common foreign body that we see is pins, and these pins are, Dr. Tejas is here, you'll be seeing so many pins we get at Wadia Hospital that unfortunately these pins are tried somewhere else. So only thing I want to tell you that if a foreign body does not come out in 2 minutes or 3 minutes, don't try to remove the foreign body or make it a prestige issue, because they land up in certain positions that it becomes very difficult or becomes traumatic for the next people to do it. Or if you cannot remove it, it is better to leave it or try it at a second stage. Now you can see that the distal end of the pin has gone into the trachea, into the other side. Of course, it's not a clear video. I'll show you the next one then. So we had to dismantle the pin. So a lot of these head scarf pins go into the bronchus, and if they are through the bronchus into the next bronchi, then even a bronchoscopy will not help, and this is the limitation that you may require. It may require to be open bronchoscopy. So this is where it has been tried outside, and when the patient came to us, the foreign body could not be removed because 2 bronchi have simultaneously shown the pin. So when they simultaneously show you the pin, that means if you remove it, you're definitely going to cause tear. So what we have done is we asked the pediatric surgery people to be there with us, and then they remove the pin from there. So whenever we try to remove sharp foreign bodies from the bronchi, never try to struggle. If it comes out with ease, if a foreign body can be removed in 2 minutes, do the procedure. If it cannot, leave it, do it at the second stage. So very important is having patience, and with patience, either it can be done at a second stage or it can be done by somebody else. Otherwise, it becomes really problematic. So this is a foreign body coin which all of you are aware of. You must have seen this is the commonest X-ray. And I remember when I was in 3rd MBBS, to quote Dr. Kirtane sir, I don't know whether sir remembers it, he had told us that in KEM casualty there was a businessman who came and said, "Mere ladke ne 5 paisa khaya hai." So the houseman came, he got an X-ray done, called the registrar. Registrar said, "Ye 5 paisa nahi hai, ye to 3 paisa hai." So he said, 5 ya 3, call the anesthetist, nikalna padega. So then when they did the scopy, he found a 3 paise coin, and with behind was a 2 paise coin. So what happens, sir, you had told us this in UG. So what happens that whenever you see have a case of a suspected foreign body, don't ask for this X-ray only, always ask for a second X-ray also, because what may happen, you may have a second foreign body inside. So second foreign body inside will be missed if there is only a single X-ray. So it is important that we do a AP view as well as a lateral view. And the second thing can be that coins going inside may just go and land in the Sholay movie coin style. You know, it may just go and stand straight. And when it is in that position, air will enter and go out. So the patient is comfortable that way, respiratory wise. So whether this is a tracheal foreign body also should be ruled out or not. So using an AP and a lateral view is very important, and unfortunately most of the patients who come, they come with a single X-ray, and we have to ask for a second X-ray before we take them up for scopy also. So even on bronchoscopy we find double foreign bodies. So bronchoscopy is done for now, you know, practically every condition in the respiratory tract. Like the pediatricians used to write investigations, X, Y, Z and all, they write down bronchoscopy as an investigation. We have done probably in the last 3 decades over 8,000 scopies there at Vadia. We've done it all the other hospitals also. So it's become an investigation. It takes 2 to 3 minutes. It is easier than doing a MRI or a scan, and it's more therapeutic also. And the thing is, who has to do? You have find everybody doing a bronchoscopy. When we started it, hardly, meaning most of the bronchoscopies were done by different departments, but there now practically all the bronchoscopies comes to an ENT. So when we conduct these training programs, we find different specialty people, all of them come to attend. But I would be biased, but I think an ENT person will be most qualified to do a bronchoscopy, because who other than an ENT would be that conversant with the anatomy of a larynx? So ideally, an ENT should be, doing a bronchoscopy, and therefore, if you take to it, it takes just 2 to 3 minutes to do a bronchoscopy. It's not only very satisfying, it gives you immediate results also, and definitely, it gives you good amount of name. So this was in American Academy where we had presented on the bronchoscopy list, and we found that it was only 18% of the patients who came to us were for foreign bodies. More than 80% of the patients came for other conditions other than a foreign body. Absolutely. It is this, just recently I think Dr. Kurup had done this, where patient came for pneumonia, and when we did a bronchoscopy, we found a fistula on the posterior wall. And therefore, you can see an H fistula. So, diagnosis of H fistula which was cannulated, and the same bronchoscope passed from the esophagus could. Yeah, so that's a H fistula. So, a lot of these diagnoses and even closure of small fistulas, we do it through the bronchoscope by pushing in tissue glue and closing the fistulas also. One way. Yeah. Now this is a child again with persistent cough, a TO fistula, and that's what I was describing to you, that after doing a bronchoscopy, On the left side, you can see air bubbles. So there's a RT put from the esophagus where push in air and you can see bubbles on the fistula. So we confirm the diagnosis of a fistula, and then a ureteric catheter 4 number is passed and tissue glue is inserted to seal off or close the small fistulas. Only it is small, then it can be closed. So a lot of various procedures are done. So typically these are the children where they've just come with cough, breathlessness, no other complication. And this was at Bhatia where, we were told to do a bronchoscopy to collect some lavage. And when I collected lavage, I didn't understand what these pieces were. And then the father told me that he had gone to McDonald's and had chicken fries. So even chicken fries can come inside. So you can't imagine what is the foreign body inside. So what happens with the foreign body? First of all, there is no history. The child is smarter than the parents, caretakers. The changing signs, as time passes, the signs keep on changing. Initially, in the first week, they are treated as laryngotracheobronchitis. In the first month, they are treated as pneumonia. Second and third month, they are treated as asthma. After 3 months, they are treated as tuberculosis. After 6 months or 1 year, they are treated as MDR, multi-drug resistant tuberculosis. So keep on changing, and the problem worsens because the doctors also keep on changing. So this is what happens, and of course these are all repetitions, so I'll just go fast. You get all forms of X-rays as far as the foreign bodies are concerned. So no X-ray is a foreign body X-ray. Any X-ray can have a foreign body. This is like for lavage, where we find foreign bodies inside. This is a child with pneumonia on AKT, chest physician treating, but finally finding a screw inside. This is MDR tuberculosis, you can imagine, and so a lot of MDR tuberculosis we get where AKT is given for 2 years, not responding and finding foreign bodies inside. So these are really, you can say, very satisfying, gratifying. And this is in Ghatkupar where one of the ENTs had postponed the tonsil because anesthetist said, I think something is there in the lung, and we found a belt pain inside. So classically, when you have a patient coming to your clinic with a history of foreign body, the child is comfortable, but the parents are breathless. So you have to do something. And when they tell you, ki Doctor Sahab, aap to Bhagwan hai, so your ego gets inflated. You want to do something. Avoid doing Heimlich's maneuver and all, unless the patient is blue or not breathing, because you could shift the foreign body from the bronchus to the subglottis and it can choke up. Or if it is sitting nicely in the esophagus, it will come up and it can block the laryngeal inlet. So unless there is a condition where the child is pulseless, don't try to do heroic maneuvers, don't try to play God. Because once a complication occurs, and it has occurred somewhere, that equation of God will change. So please don't do that. All types of conditions you will get with foreign body. This I just want to show you that this is a child where there were 4 scans done, 2 MRIs, 2 CT scans, but it was not diagnosed. So even an MRI, even a CT scan can be wrong. And done at 4 different places, and we found a chest pawn inside. So therefore, clinical acumen, clinical judgment is most important. It is worth to put in a scope and see inside. So do not only rely on even CT scan and MRI as a final diagnosis. Age is not a criteria. 2-month-olds. This infant was in the medical college for 4 days, intubated, for respiratory problems, and turned out to be a 2-inch foreign body inside. We'll go. And even adults don't give history. This is an adult 78-year-old and having cough. But since most of you are seeing adult patients, I just wanted to put 2 or 3 of them. And we found that there were some Ayurvedic tablet which was there inside. Or you may even find a beer cap. Somebody had a party after a week, throat pain not disappearing. In Bhatia, in fact, I did a scopy, and he did not know what has happened. And when I did the scopy, I found a kingfisher cap over there. He had a party 1 week before. So, there can be anything you may find. One of our doctor's relative who had throat pain, it was not clearing up with 2 courses of antibiotics. I said, I will see the throat inside, and I found the glycomet which he took it with the foil itself. So, you can find anything under the sun down, and So there is no, that always do a scopy and see what is there inside. Like dental bridges, so everything you can see. So why it is so satisfying that we have got incidences where my heart has stopped. The saturation of the patient has become 0. The anesthetist tells me, no, you continue. CO2 level is fine, there is no brady, you continue. So the saturation from 0 has come back again to 100 within 60 seconds. So saturation has changed. It is like a Ferrari within 60 seconds from 0 to 100 in no time. So the saturation goes down very fast, but it comes back also very fast. So it is not only satisfying, it is very rewarding also to do a scopy. And what I wanted to tell you is, however advantageous science has become, we have 4K. Just now we heard a talk with 8K images. HD, everything is there, but still a rigid bronchoscope made 100 years ago by Chevalier Jackson is still, it rules the roast. Still you require for when there is a foreign body inside, it comes to an ENT and they want that ENT person, you remove the foreign body for us. Whatever the advances in science, but putting a scope inside gives you saturation, gives you airway, you can do suctioning, you can do a procedure, you can do therapeutic procedures. So, however science will advance, but this will never be out of space. So, it is very simple and it is important that you do not invest big in any instrument, you just have one bronchoscope and that will help you for life. That will make life comfortable. Don't go in for any of these advances. So thank you for your attention.
Thank you, Divya. Fabulous presentation. Any questions from Divya? Yeah. Before we disperse, I would just like to make a few comments because he talked about, the most difficult foreign body I had to remove was a camera capsule that is given for GI endoscopy. It's a nice, smooth, round capsule. This 82-year-old Arab patient swallowed it, and instead of it going into his GI tract, it went into the right bronchus. And there was nothing, no instrument by which we could catch it and remove it. And finally, we had to use one of those Dormier basket and removed it. And one of the worst foreign bodies to have is a tamarind seed. Yeah, you try to take it out, it's too big to come out, splits into two, and where it was in one bronchus, goes and blocks both bronchi. It has happened to us, and the first thing to do in that case was go in, pick up the seed from one bronchus and jam it into the other bronchus first. And then we had to do a tracheostomy because it was not coming out from the vocal cords. The importance of lateral view is really important. I'll give you two examples, just bear with me. One was this lady, old woman who came with 5 paisa coin. It turned out to be, I was taking a clinic in the side room and 3 and 2 paisa. But I had another child, absolutely comfortable, and the mother said, and she had a bit of hoarseness of voice, but now she's completely all right. I said, do an X-ray, and we saw hook. The children have the dress hook near the larynx area. But she was very comfortable, and I just asked her, was this dress taken down before the X-ray was taken? He said, no. I said, what you're seeing is the hook on the dress over here. So that's okay, go away. And I continued with my clinic. 20 minutes later, they came back saying, the mulgi khokli hai, baga kai nigala. So lateral view is important. I'll tell you one of the cases that I've seen during the riots. A man was brought in from another hospital with a knife handle sticking out of his chest. And the plain X-ray he was carrying, X-ray chest, that's why he was sent, that there was a knife going right across, big 6-inch blade going inside. So looking at that, the senior registrar who was there, take him on the table immediately, and they opened the chest. And there was no knife inside. The knife had hit the rib, and it had passed completely outside the lung to the back like this. But if a lateral plate had been taken, we could have avoided the craziest foreign body, well, not the craziest, but two things: never take things for granted. I had a patient, 1-year-old child, sudden stridor. Her brother, who was 2.5, 3 years old, was brought in. He had been whacked because the parents said he has hit her on the neck with a hammer, because he was found next to her with a hammer, and the child suddenly became breathless. So I said, let's see what is there. The anesthetist did not paralyze the patient, just put a laryngoscope after a little sedation, and said, so there is a hematoma just under the vocal cords. I can see a hematoma there. If it's a hematoma, I said, okay, you put in a tube, will suction and everything would be okay. So they gave scoline. Couldn't intubate. Child's SATs went down, and I had, I think, one of the fastest tracheostomies I've done in a 1-year-old child. Put in a tube, and then I put in the scope. There was something hard. Took it out. It was an apricot seed, jardalu seed. And that poor kid who had been hammered back in blue for hitting his sister on the neck, actually what had happened was the sister was sleeping there. He ate the apricot and he tried to break the seed. The seed flew off and the kid had aspirated. So never take things for granted, be prepared for the worst. And incidentally, I must mention this here. 1970s, Dr. V.P. Sood was doing a rhinoplasty workshop in Nasik. I was assisting him. And Dr. Kasat, senior, he said, "मी जरा जाऊन येतो, एक foreign body bronchus आली है." I said, okay, and we continued. Corridor and the other theater there, and I saw Dr. Kasat, patient, young child taken on the table, and I saw Dr. Kasat standing there with a clear headlight. मतलब bronchus foreign body, clear headlight ने क्या करता है? And after 10 minutes, he was back. Hardly foreign body, there was a peanut, I removed it. But I said, sir, what were you doing with the headlight? He said, नाही, ट्रेकिया एक्सपोज केला, कट घेतला. म्हटलं का सर? आमच्याकडे ब्रॉन्कोस्कोपच नाही. We don't have a bronchoscope. Don't have a bronchoscope. What they were doing was, foreign body bronchus, they would expose the trachea, take a small linear cut, headlight, long-bladed Killian speculum, and he says, we have removed thousands of foreign bodies like this. In this civil hospital, we do not have a bronchoscope. But this was the first time I have heard this technique, and they were successfully doing it. Necessity is the mother of invention. Anyway, Divya, thank you very much for a wonderful presentation.
I request Kirtane sir to please have a token of gratitude to Dr. Divya Prabha. As we are approaching to the conclusion of today's 14th ENT Conclave, now it's time to honor our mentor, the brainchild of this ENT Conclave, who is supporting day in, day out for arranging the speakers to get everyone on the board, our Guru, Dr. Milind Kirtane sir. I request our cluster head, Hari Krishna sir, to please step forward and felicitate Dr. Milind Kirtane sir. request our AVP, Mr. Rana Ghosh, to please have a vote of thanks.
Thank you. Hello. I think a wonderful session. Thank you very much. And Alkem sincerely thanks to all the speakers, moderators, for enriching the scientific content of ENT Conclave. We also thank the delegates for gracing the great occasion, the program, in their very, very busy schedule. Special thanks to our mentor, our guru, Dr. Milind Kirtane, for putting in world-class academic feat. And thank you very much for being here today. And I definitely commit on behalf of Alkem that in the scientific endeavors in the days to come, we will continue to be one of the front-ranking companies. Thank you very much. May I request all of you to join for lunch break. Thank you.
You will have some patients who will require increased stay, and certain patients where the tumor has gone intracranially, you will also find that these patients will have an increased need for rehabilitation or prolonged ICU care. So how do you define prolonged ICU care? Is any patient who requires more than 10 days stay in the ICU, we categorize, and this is the WHO definition of prolonged ICU care, is any patient who requires more than 10 days stay in the ICU. So if you take an average of about 25,000 rupees per day in the ICU, if the patient is on ventilator, and if the patient is not on ventilator, at least in Bangalore, the cost is around 15,000 rupees per day in the ICU. You can imagine that itself contributes to a massive amount of billing. So how does the cost escalation happen? So we found that of the primary patients that we operated, the average bill that we build up was around 4.93 lakhs, was the average bill that a patient has to bear when they undergo the surgery on the first time. If you compare this with those patients who underwent surgery the second time, there was a cost escalation of 102%, wherein the average bill was about 9.8 lakhs. And the patient who underwent 3 surgeries, the cost escalation was by around 234%, where the average bill was around 16.4 lakhs. And those patients who underwent surgery for more than 3 times, the average bill was in the range of 24.3 lakhs, and the cost escalation was around 395%. So this is what we found in our data. So all our patients who underwent surgery, we did a distress screening. This is again indicated by the WHO to undergo. We have something called as the NCCN guidelines, where we do a distress screening. You have something called as a distress thermometer, as you can see here. So patients who have minimal distress to extreme amount of distress gets documented based on questionnaire. And we found that those patients who had revision surgeries, obviously the distress factor was much higher. One is they had this feeling that they cannot get rid of this tumor. Second thing is also the escalating cost which added to their distress.